welcome you all in Monsoon Dsgecon 2025. We'll start with the first lecture. I request our chairpersons, Dr. Ajit Gundewar, Dr. Maruti Takle, Dr. Girish Borauke, and Dr. Sunil Karande. Okay, so I request the Ramsi sir to chair this session. We all know Dr. Vaishali madam. She is a professor and medical superintendent in D.Y. Patil Medical College, Kolhapur. I request her to start her session.
थोड़ा अडकले. Thank you. So Vaishali is going to talk to us about I in Jai. Make that out.
Good morning, everybody. First, let me thank DSG and Dr. Dharamsi in particular for inviting me to give a talk in today's monsoon session for DSG. When Dr. Dharamsi sir asked me to give a talk, I was wondering what is it that I'm going to teach this August gathering out here who excel in practices in GI. I have kind of shifted my focus from endoscopy to open surgery, and that also now, from that, I have kind of given much of my time to administration. So it was kind of challenging for me to decide what I should talk on, and then this new kid on the block, which all of us are going to be slaves of in the near future, I thought I would talk on this. So without even realizing, AI has actually crept into our daily life. We are doing so many things without our knowledge, which AI is capturing. We have virtual assistants, Siri, Alexa. We are using smart devices in our home, smart lighting, smart streaming devices. It is all capturing what your preferences are, what you like to watch, and when you like to watch. Even without having self-driven cars, our present cars also have an AI mode. Your parking assists are again AI. We are all using our health devices, wearables, how many steps we walk every day. Okay? These are all monitoring your SpO2, monitoring the pulse rate. All of these are AI. But the major impact of AI is going to be in healthcare, and that is what Satya Nadella has said, that AI is perhaps the most transformational technology of our times, and healthcare is perhaps AI's most pressing application. Even Tim Cook, he says that medical health activity is the largest or the second largest component of the economy, okay? And Google Health is already there for us to start using. So what exactly is artificial intelligence? So artificial intelligence refers to the capability of the machines to mimic human-like intelligence, enabling them to perform tasks that typically require human cognitive abilities like learning, problem solving, and decision. Essentially, AI aims to create systems that can reason, understand, and in ways that are characteristics of human intelligence. So it all started in 1950 when Alan Turing devised the Turing test. Now, what is the Turing test? Turing test is the ability of the machines to mimic human beings. So this test was that an individual was made to recognize whether the person who is answering him is a human or a machine. And if the machine passed this test, that means the human could not identify whether it was a machine or a human, then the machine used to pass the Turing test. In 1955, John McCartney coined this term as artificial intelligence. And then the progress started. In 1997, IBM's Deep Blue bet Garry Kasparov in a chess match. In 2011, Apple introduced Siri. We are all using Siri now. In 2014, Amazon developed the Echo. In 2016, AI started partnering with a lot of other firms. And Microsoft then came out with Tay. But Tay was a disaster. Tay was a chat box which was used on Twitter, and within the first 60 minutes of its use, they started using abusing language. And that was when Microsoft had to withdraw Tay. They did bring Tay in different avatars later on, but still Tay is off the shelf now. And then we had the 2018 Cambridge Analytica scandal, where without the knowledge of people, a lot of data was used by Cambridge for their research. That is when ethics in AI kind of started developing. Then we had Erica, which is an Android design model which could help the people in the AI prompts. In 2019, we had Google Assist, which made a reservation in a restaurant. So it was an AI which made a reservation, and the restaurant people did not notice it. In 2019, machine learning and deep learning started being used as a production-ready module. And 2020, we all know, there was a lot of AI which was generated, which helped us in overcoming the COVID. So many chatbots, so many machine learning which happened, so many algorithms which were developed, and they were all using AI. That is why the research phase in 2020 COVID was very, very short. And 2021, we all came across ChatGPT, which I'm sure all of us have been using right now. And in 2022, there is now a little research which is happening on no code or less code or low code. Because coding is not necessary now to use in AI. So without learning coding, you can go ahead and use AI platforms or develop AI platforms. So the different types of AI, we have interactive AI, which are the chatbots which we use for personal assistance. You have banking details, when you go, there are certain messages which are pre-recorded, and they are the chatbots which can give you the ready-made answers. Now this is another thing, text AI with the text recognition apps which we have. So your speech to text or text to speech can be, again, an example of text AI. Visual AI is a computer vision or augmented reality. Analytical AI is used in a lot of researchers now, where all the data that is collected is compiled, analyzed, and you give a output out of that data. And you have functional AI, which is the robots that have been used in surgeries now. So what does AI actually mean? So there are various components of AI, but what is important for us is machine learning. Machine learning, natural language processing, that is the words that we speak, the language that we used in writing, all of that is captured by the computer to learn. Then you have speech to text or text to speech. You have expert systems. You can do planning, scheduling, and optimization, robotics, and vision, which is more important for gastroenterologists, which is the image recognition and the machine vision. So some terms that we need to understand before we move on, that is, what is machine learning? So machine learning is the AI's capability to learn from data, improve its performance without being explicitly programmed for that, and its ability to get better with experience. So the machine learns from the data that has been provided and improvises. Now, deep learning is a subset of machine learning that refers to the capability to learn from unstructured information. In machine learning, when you're coding, you're giving them a certain set of informations which to be used. Whereas when you're deep learning, the machine learns by itself without those rules being formed. Neural network is a kind of a brain network which kind of integrates all of that knowledge and performs specified tasks. And natural language processing is the capability of the computer to process and understand human language, called as NLP. So basically, artificial intelligence is an umbrella term which summarizes all the models which are based on intelligence. Machine learning is a subset of an artificial intelligence which recognizes the data set, and deep learning is a subset of machine learning which classifies the data sets into different headings. So as I said, machine learning is what computers analyze the data, identify the patterns, make predictions and decisions based on insights. And once trained, these machines can predict the outcomes of new, unseen data as well. Another thing that we as people who use images should know is what is CAD and CADX. that is computer-aided detection and computer-aided diagnosis. So computer-aided detection is a system which uses algorithms to analyze medical images like X-rays, MRIs, endoscopy images, your histological pictures, and they have a high potential for areas. They pick up the areas of interest which kind of are abnormal in them, and they can focus on them. Computer-aided diagnosis is a further process of this, where these detected areas are now analyzed and then decided whether they are benign or malignant. And this is coming up in a big way. So, what is AI in GI? So use of AI in GI is not new. In fact, the first global AI in gastroenterology and endoscopy summit was held in Washington, D.C. in the late 2019. So past 6 years, GI people have realized that AI is important for us. And a consortium has anticipated that in the next 10 years, the clinical application of AI in gastroenterology will positively influence patient care and the clinical flow as well. Not only that, ASG also has a different branch called as Artificial Intelligence Institute for Gastroenterology, where Dr. Pratik Sharma leads this institute, and he trains gastroenterologists in the use of AI. The mission of this is to seamlessly integrate cutting-edge AI solutions in GI care, enhancing patient outcome and driving innovations. ASG looks to the future of gastroenterology, preparing medical professions to leverage latest AI technology and provide optimal patient care. This is the Global Advisory Council for AI-GI from 24 to 27, and I would like to point out that Dr. Nageshwar Reddy is a part of this advisory council. So we are here. This is led by Dr. Pratik Sharma, and that's the council for the next 3 years. So when using AI in GI, what are the goals? The goals are to analyze the relationship between prevention of treatment techniques and the patient outcomes. So it will increase the quality, improve diagnostic accuracy, decrease the variance of healthcare delivery, enhance outcomes, and then reduce the medical cost. So what are the diagnostic challenges that we usually face in GI? Is the visualization, finding the lesions such as polyps, and the interpretation, whether they are malignant or non-malignant. So this is a computer test which is done. So the computer, simple tasks like that we do, that in the first picture that you can see, where you have to differentiate between cookies and dogs. Humans can do it very easily, but it's difficult for computers to pick up which one is a cookie and which one is a dog. So you need to feed data into the computer, tell them that's the requirements, how you can identify a cookie from a dog, and then the computer starts learning, and then it will differentiate between a dog and a cookie. The same principle is used in endoscopy images. If you feed the correct data and ask the computer to pick up a lesion, a suspicious lesion, it can do that. So that is how AI can be useful in GI surgery. So what things are on the block at the moment where AI is being used in GI? So it is used to detect pre-malignant and malignant conditions, especially the neoplasia of the Barrett's esophagus, esophageal SCC, and gastric carcinomas. It can help in endoscopies in directing biopsies instead of just relying on random sampling. So you can target the critical areas and take biopsies. The yield would be better and the patient outcome will be better. In a GI bleed, studies are focused on developing prognostic models that can predict bleeding or the need for endoscopic and surgical therapy using AI. In lower GI, probably the most important application of AI is in colonoscopies. Because as we all know, colon is one of the organs where we have a lot of folds, a lot of blind spots, and seeing those blind spots may be humanly impossible, okay? So AI can detect colon polyps in the most promising, that is the most promising area of endoscopy at present. And one of the goals of using AI in colonoscopy is to improve the adenoma detection rate in real time. Video capsule endoscopy, again, because there are 60,000 images to be examined per examination. So that is a lot of images to be seen, by a human being. And fatigue definitely is going to creep in. So AI here is going to be very useful. So the same principle of a computer-assisted detection is used out here and can be applied for detection of capsule endoscopy images. It could also be used to see the preparation of the bowel, and algorithms can be developed which will help us in diagnosing or reducing the intra-observer variability and grading of severities. So the clinical challenges that are right now faced are missed colon polyps, the optical diagnosis, and the polyp size determinations. And this can definitely be used, this can be elevated by the use of AI. So various studies have confirmed that the specificity and sensitivity of an AI doing the imaging study is for colorectal polyps is about 94 to 98%, for gastric cancer is about 89 to 93%, and for gastroesophageal reflux disease it is about 97%. There are scopes now available which use these real-time systems, integrated systems like Olympus EVS X1 and EndoEd, which provide live alerts during procedures which can boost detection rates and reduce missing diagnosis. The CAD system typically integrates into the colonoscopy equipment and uses algorithm trained on large database of data sets of polyp images to identify potential polyps in real time. So there are several clinical randomized trials which have shown that CAD platforms can significantly decrease the adenoma miss rate and increase both adenoma detection rate and the adenoma per colonoscopy rates. Can also be used in hepatobiliary pancreatic system. Lot of algorithms, lot of predictive value which is there. You can model them on detection of neoplasms, for detecting of toxicities, for predicting fibrosis in hepatitis C viruses, and in general improving the disease outcomes. So how does AI agents work in gastroenterology? There are 4 layers of it. One is the perception layer, which is the data input. All the data that you goes, all data which is there, which we are actually providing or the computer is picking up from our systems. This is all recorded together. So all the images are there. We have the electronic patient health records, EHRs, and the patient-related symptoms. Now, just the other day, there was somebody who had come to demonstrate to me a system. So what was this system? This was an AI-generated system where a patient comes to the OPD and the general information is filled up out there. Once it is done, the patient sits in front of the doctor. He relates his symptoms, and the computer gives a transcript of the symptoms. So the doctor may or may not be listening to him, but the computer listens to it and the systems are encrypted into the computer. The entire conversation is recorded. And based on this conversation, the computer now devises that what is the symptoms that the patient has. He will give you a brief idea as to what the patient has told. And from this brief script, the computer itself gives you a diagnosis with a probability. Probability 1, say 75% this patient has an acute appendicitis, 23% the patient has gastroenteritis, and 1 or 2% maybe he has something else. So these systems are already there in the market. Not only that, they would even give you further as to what. So the first step here is the EHR with the patient recording. The example here is the AI scans video feeds in real time and gives you an area of high suspicion. Then you have the reasoning layer. Reasoning layer is where the AI applies the machine learning or the large language models and deep learning to analyze whatever the data that has been fed to it. And the AI then says, assesses the lesion morphology and can give you a risk prediction. Then you have the decision or the execution layer. Here, all the AI outputs are put together and the computer can give you a recommendation that whether a biopsy is necessary or a surveillance colonoscopy is necessary. But here, the human validation is required. AI only relies on the data which is given to them, the information which is there. It does not see beyond the information. So here, human intervention is very, very necessary. And with the feedback that we give, the machine learning updates its knowledge. So AI keeps updating its knowledge. So applications, as I just told you, how can we apply AI in our daily practice? One is scheduling of appointments. That can be very well done by AI. If you know Mondays are very peak days, AI would see to it that no appointments or less appointments are given on Mondays. If you have a day which has a lot of procedures, you could tell AI, your system, and that they could reduce the load of your patient care on those days. Clinical decision supports, AI can review your reports. See, nowadays when patients come to us, they get bundles and bundles of reports with us. Okay? It is very difficult to go through each and every one of them. But AI can give you an idea, they can give you charts, they can give you diagrams as to what has been the, say, HB level in the last 2 years, 3 years, and if it has any relationship to what the symptoms the patient has. And there are chatbots which can answer questions that patients usually have, but we don't have time to answer. So after a colonoscopy, AI can scan the reports. It could give you a report ready. It could give you what is expected, the key details, the polyp size, number, the location, and it could also assign a correct ICD coding, which would be useful when we submit these reports for insurance claims. And AI could also predict whether that claim that you've submitted is going to go through or not go through. So the key sectors where AI is making an impact is, as I said, the appointment scheduling, medical record management, billing and claim procedures, image analysis, smart diagnostics, pathology automation. Now there are a lot of slides which are read by AI and a diagnosis is given. These systems are already into practice now. Disease dissection is also one area where machine learning is coming in a big way. Detection like cancers, detection of heart conditions before even symptoms appear. We all have seen how Apple Watches have predicted that this person has arrhythmias, and a visit doctor has been initiated. There are also automated dispensing systems where robo fills prescriptions and manage inventories in hospitals. There are medical adherence tools which remind us of taking medicines, and genome sequencing. Again, an area where a lot of efforts need to be done, a lot of algorithms have to be followed, where AI can be of great help. AI-powered recommendations. Well, this is something which is already there. AI is recommending us to read something, AI is recommending us to take something, but this has to be regulated. And predictive analysis as to what is this condition and how it is going to behave in the future. Chatbots are there everywhere. They answer your queries, they provide medication reminders, and even assist with symptom checks. Patient monitoring is another area where AI can be helpful, where you can have remote patient monitoring devices which are wearables which can track the vitals of the patient and alert providers to the healthcare of the patients. Telehealth platforms which automate forms, triages, and follow-up rituals visits, preoperative planning and simulation, and of course, robo-assisted surgeries. But there are certain ethical concerns, and one of them is the data privacy. But data privacy is being regulated, but even without that, so much of our data is now into the internet. So much of data is there in the wild world web. Okay? And then you have biases, because AI models can inherit biases from the data they have been trained at. All AI models are based on data. So if the data that is fed to them was not right, they are not going to interpret correctly. So there has to be a course correction. And as we say, we are all lifelong learners, we keep on learning. So many new evidences start coming, and all the new evidence now have to be fed into the computer again so that the computer can give us a correct diagnosis. And the most important, accountability. If the AI makes a mistake, then who is responsible? Is the developer responsible? Is the hospital responsible? Or is the clinician responsible? So that is a million-dollar question which needs to be answered. The guiding principles for ethics in AI is that you need to protect the autonomy, of course. You need to protect the human well-being, human safety, and the public interest. It has to be transparent, explainable, and intelligent. And it has to foster responsibility, accountability. It should ensure inclusiveness and equity, promote AI that is responsible, responsive, and sustainable. These are certain leading AI platforms. Now, ADA Check Your Health is already there. If you put in your symptoms, that would really give you what you would suffering from. We are already tired of your Google patients. Now we are going to have AI patients as well. They're going to self-diagnose. They're going to come with all the diagnoses. AI is going to give them even primary treatment, what has to be done. And again, they're going to be botched up. Path AI is another facility where pathology people are using this to read the slides, to identify, because they have to see a lot of slides, and it can become groggy at the end. So AI is there in big way. Microsoft Dragon Copilot is again helping them with all these things, and there is a Microsoft Rad Dino, which is, Microsoft is in big way in AI and healthcare. So Rad Dino helps in reading images, CT, MRI images, and it gives the diagnosis. There is also a software called as Microsoft AI Diagnostic Orchestra, which learns from the multiple LLMs and interacts like a doctor. It reviews challenges and refines each other's challenges before settling on a final diagnosis. The accuracy of this machine is said to be about 85.5%, as compared to about 20% of humans. If the same images were given to a doctor and to a machine, the machine was 85% times correct, and only 20% of the human beings gave a correct answer. Now this probably is why it can avoid unnecessary tests. So once a diagnosis is made, you do not need to go further for making more tests. But here again, a caveat, that it is not to replace clinicians, but to work alongside them. What are the limitations of AI? AI cannot learn independently. It has to be taught. Even when we say there is deep learning which is happening, you need to give the right information to AI so that it can learn. Now there are certain inaccuracies, or which are called as hallucination in terms of machine learning, that the AI inputs that are given, or AI outputs that are given by the AI are not true. And most importantly, there is a lack of emotional understanding. AI cannot simulate sympathy, but doesn't, and AI can simulate sympathy, but doesn't understand or feel emotions. So, will AI replace human beings? Well, AI is designed to augment human capabilities and not to replace them. AI makes it easier for doctors to focus on tasks that matter and can assist them by speeding up diagnosis and treatment. So whatever repetitive procedures that we have, the boring things, that can be given to AI. Human oversight is always necessary to verify whether the information that AI is giving is accurate or not. And human skills such as critical thinking, emotional intelligence are irreplaceable. AI can analyze medical images, but human doctors provide the empathy and care that the patient needs. AI is most useful when you have repetitive tasks. Unlike humans, AI cannot understand or reason abstractly, cannot create constraints or counterfactuals, does not understand causality, and cannot ask why. Human intelligence includes many complex emotions that cannot be emulated by computers, like love, empathy, happiness, sadness, fear, and embarrassment. And unique human characteristics like common sense, creativity, curiosity, and imaginations cannot be replicated by an AI. A lot of research has been happening into AI. Major journals are all publishing articles on AI. There is a book on AI called as Deep Medicine. So all of this is already there in the market. Even newspapers are not far off. Every day you would learn something new about AI which comes into the newspapers. A lot of softwares are approved by the United States. So these are the artificial intelligence devices which are approved by United States. The CADI, CADI-I, Endoscreener, GI, Genius, Magnetic Colo. These are all softwares and AI which is approved for clinical use. And these are all using the computer-aided detections. The other common tools that one can use, which are already ready into the market, are Google AI Studio, Riverside AI, where you can use your audio to text. You can transcript all your information, your OT notes, operative notes, which can be used to be translated. Then AI Explorer, Perchance AI, which is an image generated, Hello AI is a text to video, Scribber, Microsoft Copilot. And using Copilot is really very easy. It's like ChatGPT. You put in any prompts into that and it will give you a summary of whatever is there. See, as I just said, AI uses data which is already there. So if you're researching a paper, going through so many papers is not going to be productive. So you give the prompt to the chat boxes, ChatGPT or Microsoft Copilot, it scans through all the literature and give you a gist of what you're looking for. And I must say, while I was preparing these slides, I have used AI.
1 minute left.
Yeah, I'm almost through. So these are some of the courses in AI which are offered right now also. Some of them are free, some of them are paid. And one of them, AI for Medical Professions from IIT Hyderabad, has the first batch started in June 2025. The next is in November. Even ASG, the AIGI website that I told you, it offers small short courses for gastroenterologists. And some of them are free. So to summarize, artificial intelligence continues to grow with a key goal to improve overall quality and clinical practice. Image-based specialties such as endoscopy have most to gain. Once the technique correction is maximized for colonoscopists, AI may help to address clinical pain points. And by leveraging artificial intelligence in hospital settings and clinics, healthcare systems can become more smarter, faster in providing the care to the patients. So thank you for your patient listening. And as Ginny Rometri, former CEO of IBM, has said, AI will not replace humans, but those who can use AI will definitely replace those who don't. Thank you very much.
Thank you, Vaishali, for that eye-opener talk on AI. I can think of two things. One, first MBBS will be anatomy, physiology, biochemistry, AI.
Yes.
It will become compulsory to learn AI in medical college. So are we engineering doctors or doctors who have been engineered? I'm not sure about that. Second, it makes me and Vivekanand Kulkarni obsolete. We are not tech savvy. I presume we are not tech savvy. And down the line, we are going to be obsolete actually. It's a good idea to retire at the age of 40. Let the computer take over.
So one of the goals of the NMC is that all IMGs are lifelong learners. We cannot stop learning, sir. And as we have mastered our smartphones and computers, I'm sure we're going to master AI also. We need to be good masters to slave AI.
Hopefully. Some from the floor, couple of questions, please.
Who?
Feeds the data.
Sir, these are all data that we have provided. The images that we have sent. So the computer is just analyzing these images. So
Vijay, you'll be called MBBE, not S.
MBBAI.
Bachelor of Medicine, Bachelor of Engineering. So that's the future.
My question is, is there any study, the human data or human clinical trials which are done and AI-based trials which are done? So was there any difference of these trials?
there was significant difference. The machine was better than humans.
Okay.
But as I said, machines only see the data. They don't see the person behind the data. If the machine is telling me that this is a patient, I need to operate him, or say a case of CA colon, and the machine tells me that go ahead and do a colectomy. But when I see the patient, a very frail patient, not fit for surgery, anything, I am not going to do such an elaborate surgery. I would probably do something which is more conservative.
Palliative care.
Yeah.
One more thing I want to say, the cost of therapy will go up, one.
Yeah, that is it.
Second thing, madam, you have said that there are some pitfalls like who will be responsible. I'm telling you, there is always Padavat. The radiologist, the way he writes, please do this, please kindly correlate clinically. Same way they will say, please correlate with AI.
No, on the contrary, AI will generate and he will
Yes.
say, confirm with human.
Correct.
Yeah, even in surgery, people are using that AI system. Suppose somebody has done a laparoscopic cholecystectomy and the AI is asked to see how he has done. So it will give you the points where you have gone wrong, where you can improve upon. So that can be a positive point we can take from AI in our surgical skills to improve.
Recently, I heard a podcast from John McCarthy, who is supposed to be the father of AI. And he said, now, whatever my life is remaining, my next aim is just to stop AI for the biases it is creating in human behavior. And it can change the entire world with the biases because there is no empathy and sympathy and compassion to the AI. So that is a very good podcast. Somebody can listen if they are interested.
If anybody has attended any of the recent gastroenterology conferences, the colonoscopic polyp detection system of any of the major systems, they have shown a significant improvement when there is an AI-based
Yes.
system to detect polyps.
Yes.
So it's definitely where to use and when to use is up to us. But probably, as you said, the last line, people who are using it will have a better judgment of things than people who are not using it.
Even I think capsule endoscopy and many.
Now, capsule endoscopy, when I was studying, it used to take 2-3 hours to analyze the entire video.
Yeah,
But now in
yeah.
15 minutes, the AI shortlists, these
yeah.
are the potential points, and we go through that, and in 15 minutes, you can give the report.
So we have been using AI for last 2 or 3 years now, and we are part of multi-center study which is led by Pratik Sharma for India. We're going to be putting the draft in, but there is some significant problems which we are here. I'd just like to mention one thing is the lecture was amazing, madam, really good. It is one of the best ones I've heard on AI because all of us look at very small part, just endoscopic images, image picking up. We never look at it as a complete lecture. You spoke about a system. This system is called as Ognito, which is there, which she was talking about, which picks up all the history taking and makes you a summary and give. KIMS has incorporated on its panel, and I had a friend of mine who's been using it for a few years now, and he believes it's a very, very good way of making summaries. For people who don't write history, we write 2 points, abdominal pain, no blood, no alarm symptoms, advice. But they make the proper history, which you have anyway taken, is all mentioned out there. With regards to, we use the CADI system, and this is my 3rd year with using it. Our problems are 2. One is India has a problem in polyp detection. Forget adenoma detection. We are very, very far away from adenoma detection. So polyp detection, do we improve that? The strong answer is yes. In case of CADI, if somebody is used, you get a noise also, you get a box also. Both the ways you can pick it up. In LCI, when you have an LCI mode, you easily pick it up. Then comes the issue of adenoma detection. But the bigger question is, whom do you see and discard? Whom do you see, resect and test? And this is where money will be saved. So there is a strong belief that if you see, discard, you're saving money. But if you're going to be seeing and making mistakes with what you're picking up and you're going to send everything for histopathology, then you're going to be increasing to the cost. So this is one point which we have to know. In upper GI endoscopy, it is mainly meant for intestinal metaplasia versus early gastric cancer. And that is where AI plays a role. It's also a very good system, but the data is much less because the fed data is much less with regards to upper GI system. Whereas for lower GI system, it is already established. So these are few parameters. I have had multiple meetings with Dr. Pratik Sharma. The few things are AHG still does not recommend it. So it is not in part of their recommendation, but it is compulsory. As of now, litigation, the doctor is responsible. Nobody else is responsible as of now, because if you detect, resect and don't send for testing, you are responsible. If you detect and perforate, you are responsible. If you detect and send and you say it is cancer because the machine said it was adenoma with high-grade dysplasia and it turns out to be benign, again you are responsible. So this is where we are with regards to, but what she said in the last line is, those days are gone when you can say it doesn't exist here. Everybody is going to use it. We are anyway uses it in our chat GPTs and whatever else, other prompts which are using for day-to-day life. And it is here to stay. We need to learn it. And it will help your clinical practice in the future.
Thank you.
so much.
Okay. I request we'll have a questions in the lunch time, so to avoid the constraint of the time. I request moderators to felicitate for a very nice lecture given by Dr. Vaishali. I request Siddharth for felicitate moderators. Ajit Gundewar, Dr. Dharamsi sir, Dr. sir. Thank you, moderators. Next session is on panel discussion. So, upper GI bleed. So, you all know Dr. Nitin Pai yesterday, he has given a very fantastic lecture on world photography. So, panelists for this session are Dr. Vivekanand Kulkarni, Dr. Harish Peshwe, Goa, Dr. Deepak Patil from Kolhapur, Dr. Vijay Shivpuje from Solapur, and Dr. Vaibhav Mudhale, Kolhapur.
गुड मॉर्निंग एव्हरीवन. संध्याकाळच्या लेक्चरला ह्याच्यापेक्षा 10 पट गर्दी होती.
बँकवेच्या आधी होतं ना.
मला कळलं ते मॅडम, मी ते म्हणणार नव्हतो. Very few times do you go to panel discussions nowadays when you're double blinded, like sir said. I did not know who the panelists are and they do not know what the questions are. Rarely does this happen. Everybody asks for the questions. So either we have a brave panel.
We'll see at the end of the session.
Good morning, ladies and gentlemen. I know it's a Sunday morning and whoever is here, we are thankful for that. So, GI bleeding remains even today. You have 8 to 10% of mortality in this country. World data says morbidity is still 30 to 40%. So when we stand here as gastroenterologists or endoscopists, remember we stand with a lot of people who are behind us. I always say that I appreciate people who are in tier 3 cities who are doing such amazing work despite having a lot of limitations with regards to teamwork. When we stand here, we are talking for having taken for granted an intensive care unit, easy availability of CT, MRI and angiograms, easy ready availability of an IR specialist, surgeons at our beck and call, anesthetists for every case, and despite that we see morbidity and mortality. So when we have people who are doing cases without this team which is easily available or in one place at one time, I'm really appreciative. So what we're going to try and do with this esteemed panel here is, though I think it's a bit skewed, this panel, because unfortunately I have only taken non-variceal bleeding. Because I knew surgeons were on board and they're more or less obsolete there. But even in non-variceal bleeding, also surgeons have relatively obsolete. So I think Dr. Dharamsi has not done the right job here. A few of these gastroenterologists who are smiling downstairs, make them come and sit up because they are really more needed out here. So we'll touch causes and pathophysiology. Yeah, I think so. I think you need to come up. We'll do 3 important things: pre-endoscopy, endoscopy, and post-endoscopic management, and look at certain special situations. So we're going to do a case in point here, and so we'll try and take the panel ahead, and maybe anybody can, out of the team, maybe Harish, we can go just because you're right to left. Just summarize. So when you see somebody who's 82-year-old, comorbidities, dual antiplatelets, Melina following some backache he had for which he took NSAIDs for 3 days, has tachycardia, has hypotension, was obtended, has giddiness. So what are the few things which, run through your mind, and how do you approach cases? Because this is day-to-day practice. There's nothing hi-fi in this discussion.
Thanks, Nitin. So when you see an 82-year-old male, the first thing I would think is age is there. This is a high-risk patient, IHT, diabetes, antiplatelet usage. So and having Melina. So now this gentleman definitely needs to be approached in a much cautious manner. Though he appears, his BP is 90/60, he is hemodynamically unstable, so he requires a proper evaluation in the ER, in the casualty, and probable, I would say that he needs to be admitted into a high dependency or an ICU straight away. After which he needs to undergo first hemodynamic stabilization. He needs to be stabilized. There's no point in rushing for an endoscopy just because of pressures from various sources, from the relatives, from your staff, and from the referral doctors maybe, but this patient, this gentleman would need to be stabilized first. After stabilization comes the issue of endoscopy. The causes could be varied, but commonly in elderly people would be an ulcer or basically nonsense is non-varicose. I'm looking at an ulcer issue only. And yes, the other part would be that after he gets fully investigated, then would be the decision for an endoscopy.
So remember in world data, non-varicose bleeding account for 60 to 70% of bleeding. From Indian data, 60% is still varicose bleeding, and you add another 10 to 15% if you include PHG bleeding or vascular ectasia. So we are looking at almost 70% of all our bleeds amongst published Indian data is still varicose. Dharamsi sir, when you see patients quickly, how do you triage these patients? Like who goes where? What is your decision making? How urgent is urgent? Do you think data supports today emergency endoscopies in people who have got low risk stratification? What is your policy for the 9 p.m. to 6 a.m. call? So today, if 9 p.m. your phone is off, so if Siddharth has to be pushed to doing an endoscopy between 9 p.m. to 6 a.m., who are the ones you're going to say, no, you get out of bed and bloody well go and do this?
Difficult question to answer, but the data is definitely that there is no absolute emergency to do it between 9 p.m. to 6 a.m. No absolute indication unless you have a massive bleeder who is in hypotension like this man is, who is got comorbidities like this man has. Probably this is one person I would go and do an emergency scopy. From my hospital to my residence or the other way around, it's only 2.5 minutes. So that mental block is not that I have to travel half an hour and then see this patient. So that is not there. So yes, given the situation that I'm in, I would say yes, go ahead and do a scopy in this man who's comorbid and who's got hypertension, is bad, often dead. He would be in the ICU and as soon as possible get one blood and do an endoscopy.
So Vivekanand sir, who is the patient whom you're going to say, "Kya re mala noko phone karo, the surgeon las phone kar direct"?
Look, this particular patient is often dead. He has got a hypotension. Basically, according to the Glasgow criteria, we have to see exactly, we have to do the risk stratification in this particular patient. Now, number one is that once you have seen that hemodynamically he's getting stable after giving IV fluids, you have put a catheter, the IV line, you have checked the hemoglobin. Possibly in my case, I will always put a Riles tube only because there is only melena, there is no upper GI bleeding, just to know whether it is a upper GI or it's a, somewhere else. And in case if you have put a Riles tube, if there is a bright red blood, obviously we have to do endoscopy as early as possible compared to a coffee ground. And if it is not very copious, I think always I will say that we can wait for the next day morning. And endoscopy, the timing of the endoscopy.
I think we'll get,
depends.
so we'll just go through one.
Yeah.
Just a quick question to any of the surgeons who are on stage. Riles tube, do you know what the recommendation is there in data? Do you put a Riles tube for every patient? If you have blood, what does it mean? And if you have a bland RT, which is called as, where nothing is picked up, what does it mean? Anybody wants to take this up? Do you put Riles tube in every patient or bleed?
Not really.
Okay, so recommendation says it's not necessary, it's not compulsory. But having put and you do not find, what does it mean? So does it mean you can sleep the night? So there is 30 to 50% chance that you will not pick up in a Riles tube, and out of which 70% is because you have wrongly placed the Riles tube. So remember that if you have it coiled in the fundus, you're not going to pick up blood. If it is there from one of the, from duodenum or beyond, you may not pick it up. It's in the proximal stomach because there's always not some backwash out there. So these are few points to remember. Any thoughts about ice cold lavage?
No.
And do you think
I
it's indicated?
There is no usefulness of giving ice cold lavage. But in this particular case, because there is only melena,
Yeah.
we have to localize the bleeding.
Yes.
And for that, I think we have to put a Riles tube.
Yeah, but though this point is taken, sir, even if it's a negative Riles tube, it still does not mean he's not bleeding. So it's not that, I understand if it's fresh blood, red, ongoing bleeding, yes, there is an emergency to a certain stage, but there is 30 to 50% chance that you will not pick it in spite of having put in Riles tube. Who are the
Within, I just want to have a comment. Ice cold lavage, ice cold, it is a counterproductive rather. It
Yes.
can cause
Because of-
hypothermia and coagulopathy.
and more importantly, aspiration. In obtunded patients, the bigger worry is aspiration. If I can ask this, out of all the 3 surgeons, how many of you all would like to be involved at days 0 or 0? Or how many of you all actually see GI bleeds in today's day and age? And more importantly, how many virgin GI bleeds do you see? Which means, is somebody not touched by an endoscopist before they come to you?
We are interested when patient comes, day 1, if gastroenterologist feels that this might require surgical intervention, so on day of admission, we should be involved from the beginning. That is the...
On day of admission, do you involve the gastroenterologist in the beginning?
No. If GI bleeding, if treated by a gastroenterologist, he feels that...
No, I understood. Yeah. I'm asking you the other question. When it comes to you, day 0, hour 0, do you involve a gastroenterologist every time?
Yes.
Nitin,
So this has changed a little bit now. Few decades ago, nobody would have even looked at the gastroenterologist.
Scenario in our area is different. 90% of us have small nursing homes.
Yeah.
And the patient come directly to us.
Correct. So जरा जवळ बोला फक्त.
The patient, they come directly to us, and we have to start the treatment. We have to assess the patient, start the treatment, and if required, we ourselves do endoscopy.
Correct.
That is the scenario in our area.
Correct. But there are a lot of surgeons, sir, here who do only diagnostic work. Do you think these are the right patients for them to do diagnostic work on? Which means they know they can see, but they know they can't do anything. Do you think these patients should be touched at this time? Obtunded patient, elderly patient, our case.
Not in this case, but patient who is hemodynamically stable, diagnostic scopy can be done by us.
Yeah. So just remember, be careful when you're touching patients, especially GI bleeding, because you sometimes can do more harm than good. I want to touch this, and Harish can take this question. Most important question, resuscitations, blood for blood, IV fluids, which type, and what does data say?
It's quite a lot. So let's start with the first one. Initially, when you investigate the patient, the goals of fluid resuscitation are definitely to restore the perfusion. So you are looking at hemodynamic stability, a blood pressure typically of above 100 systolic. And I think so, usually our practice is to give Paxils. That's what we do. If hemoglobin is less than 8, it is hemodynamic instability. Crystalloids versus colloids, well, usually we tend to use Hemaxil. The starting off point is usually putting a central line in all these patients. We as a practice try to use 2 Gelcos, but 2 Gelcos sometimes they're not enough, then a central line placement is correct and would help in hydration better of this patient.
Everybody central lines in smaller places, would you be doing this?
No need of central line immediately.
Okay.
You can put a...
I think so in this patient.
In this man, central line.
In this man?
Okay. So just, I will touch specific questions and only specific answers. We'll not go, so that we have good take-home messages. Blood for blood. Every patient needs blood. Do you over-transfuse, do you under-transfuse? And what is your aim? I'll take Vivekanand Kulkarni, sir.
I think blood for blood is only if the hemoglobin is less than 7.
So please remember, under treating with blood transfusion is the way forward. Do not over-treat, do not bring pressures high, especially in portal pressures, do not try and bring them very high. If it's less than 7, you give. Blood for blood is usually a good answer. In cases of coagulopathies, when you expect, then whole blood is also a good answer. Rarely try and correct it above 8. So try and keep it between 7 and 8, you're good to go. Anybody on crystalloids versus colloids? Now this is a specific question, whoever wants
Only
it.
crystalloid initially.
So remember, crystalloids are good enough, they're extremely cheap. Harish mentioned colloids, but they are expensive. But only caveat here is, for every 1 unit of blood loss, you require 3 times the amount of crystalloids. And the crystalloid of choice is ringalactate. So remember, not normal saline. An important caveat is metabolic acidosis, especially lactic acidosis, because that means there is end organ perfusion damage, and then these patients, of course, a line is necessary. In an elderly patient, I do agree with Harish, a line is necessary. Overload is a problem. A little problem comes now in this patient is on dual antiplatelets. So what happens when your patient is on dual antiplatelets? We have DOACs, some of them are anticoagulated. How would you manage? Sir, Dharamsi sir. blind lines, and wait for something. What are the rules?
You can't stop the antiplatelets now. So that's immaterial. But he was on antiplatelets. So definitely.
No, does it, a patient with antiplatelets, a patient without antiplatelets, in moderate to massive bleeding, do the rules of the game change?
Not really.
So this is very important. Remember, nothing changes. A bleed is a bleed in every patient. What is required for saving life is more necessary than to follow the, and remember, even if you stop today, the action is there for 5 to 7 days. So nothing is going to change. Out of that ones, which are the ones you are comfortable in? So especially, I'll give you specific ones. Vitamin K antagonist, which means warfarin, or the newer dual anti-platelets which are there, especially DOACs. And out of that, there are only two main, dabigatran or apivaxan. Anyone wants to answer this? So remember, dabi rarely causes bleeding. So it's usually relatively very, very safe. And remember, the half-life is 1 to 3 days. So you don't need to worry with them. With regard to vitamin K antagonists, try and replace them. The replacement, you should wait for at least 3 to 6 hours. So nothing, it doesn't, a shot of vitamin K on the table, it doesn't happen that way. So you get some time. So the consensus, remember, under perfuse, under blood transfuse, adequate crystalloids. Remember, it's 3 times, ringalactate is drug of choice.
Nitin, what is the role of Himaxil?
So it's a colloid. So Himaxil is, it's a very good agent, but it's an expensive agent. So there is no data of head-to-head. Crystalloid is equal to colloid. Crystalloid is cheaper, easier available, and therefore crystalloid is believed. But if you ask me, is there head-to-head data, crystalloid, it's not there.
1 minute. You said 7 grams. I think that is for varicose bleed, where you underperfuse them. For a normal non-varicose bleed, you could go to 10.
So, sir, pre-endoscopy management is equal in both varicose and non-varicose. Yes, we have some caveats for varicose bleedings. I agree to that. Broad consensus is 7 to 8. I'd like Harish to take this. Important ones, and more importantly, is not for deciding who is bad, because many parameters decide, but it is very important, especially in where social health standards are there, of who is good and whom can you discharge, whom you don't need to admit, who can be sent home and routinely endoscope whenever their turn comes next 3 to 6 months in social countries. You and me will do it that night, next day morning, but the rules or the recommendations say, who do you send home? And that is where risk stratification comes.
So basically you're asking us to say which patients you would send home or which patients you would scope immediately. Am I right on that?
No, I want to ask you, what is your risk stratification idea? And scoring systems were mainly meant for deciding who is safe.
Okay.
Because who is bad is apparent to everyone.
Yeah. So basically the risk stratification among all these, it's very difficult to use it in critical patients when they're in the ICU, when you're in the casualty emergency. So what we tend to do is that patients who are hemodynamically unstable, try to get them as far as possible to stability within the next 4 to 5 hours and do an emergency scoping.
So the long and the short of it actually, Harish, is those with low scores, immaterial med score you use. The one which is used as standard for most studies is the Glasgow Blatchford score. The answer is whoever is 0 to 1, you can safely discharge. When you safely discharge a patient with non-varicose bleed, Dharamsi sir, what is your medication which you are giving these patients? Basically, what is the role of PPI? What is the role of antibiotics? And how early will you call him for endoscopy? When you're discharging patients, low score, not this patient, low stratification, a young man, NSAID intake, 2 episodes of Malina, no postural drop, nothing of that sort. You want to send him home, far load hai, aaj nahi karna.
Yeah, I think that's fair. So you could do it after a week also, it doesn't matter.
Dosing, what do you give? What is your prescription say?
So PPI,
Yes.
40 milligrams per day.
Okay.
Oral.
Do you have a choice of PPI? Is any X PPI better than other?
Not really.
PCAP better than
they all
non?
equal. They all equal.
Okay. So PPI by any other name is still a PPI. The standard dosing is believed to be 40 milligram OD. The minimum dosing is believed to be 7 days. H. pylori needs to be tested ideally at the index procedure time. But the treatment of H. pylori can wait because the side effects, vomiting, nausea, which comes with the antibiotics can wait. So that is what data says. I'll pass on the question to you. Which is the patient who require high dose PPI? And why is it necessary? Does it matter? In 2 parts, morbidity, mortality.
a patient who is bleeding actively, these patients need a high dose PPI. If you are suspecting a peptic ulcer bleed, these patients require 80 milligram of PPI stat IV, and followed by 8 milligram per hour in future.
So the answer is correct. It's 80 milligram stat, 8 milligram per hour for 72 hours, but bolus is equal to continuous injection. So if you don't want to give a pressure pump, costing, continuous medication, you can give 40 milligram boluses BD also. That is equal to each other. PPI of any form is okay. The role of PCABs, which maybe Dharamsi sir, PCABs, just a mention or two.
Just the same.
Yeah. So actually just the same. Whether your pH comes to less than above 4 in half an hour or 6 hours, in broad terms it does not matter. But an important question is, do PPI change mortality? And that is important.
I think that's Kuru's study, which has proved very clearly that persons given PPI do much better.
So the better was because of rebleeding. It was not regarding head-to-head studies, but head-to-head studies and recommendations say mortality does not change, but morbidity, rebleeding rates definitely do improve. So you may give injectable for 1 or 2 days and then continue. Our patient was resuscitated in ICU, received crystalloids, received PCV, has a high bleed risk rate because of obviously antiplatelets age. Stopped both antiplatelets now, but we know action is for 5 to 7 days, and prepped for emergency endoscopy within 4 hours of admission. Do these hours matter, Harish?
Yes, I think so. This is a very important point to note. The last one you made, prep for emergency scopy within 4 hours of admission. A lot of times we decide stabilizing the patient, and sometimes this can just take long. It's very important to note that 4 to 6 hours is the time period wherein you should ideally try to scope the patient so that you can achieve the best benefit of it. That is one. Secondly, is that you asking? Sorry.
No. When you do prep for emergency endoscopies, what are the things which go in your mind? And so this is very, very important. So how do you plan? So I ask, it's a simple question. I'm planning endoscopies. Technicians, nurses, emergency OT, backup of people, anesthetic, intubation.
So the first question becomes where to do the endoscopy, whether in the ICU or bedside endoscopy, or whether you want to do in the endoscopy room and the OT. Usually the choice would be where the best backup facilities available. Usually it's in the ICU bedside or in an endoscopy room if all the backup facilities are there. Secondly, I think so the choice of an anesthetist, intensivist, anesthetist has to be on hand, because during the scopy sometimes patients can crash and they need to be resuscitated.
Do you intubate all patients?
No, we do not intubate all patients.
If you put a scope in and see massive blood, will you intubate?
If you put in a scope and then we see massive blood, yes. That's
if
the time
the patient has
we'll have to
variceal bleeding, is obtended hepatic encephalopathy, still will you intubate?
So these are case-specific situations, but not all cases.
I think blanket answers should still be yes.
Yes.
Because you need to type, it is better he comes out alive, rather he comes out with a complication with regards to bleeding. Vivekanand Kulkarni sir, tumcha instrumentation checklist. What is your checklist? What do your technicians expect? And at what stages will you have your surgeon standing next to you?
Well, the instrument checklist is that in case we are talking about non-variceal bleeding, then we have, first thing is that we should have a adrenaline, diluted adrenaline in place, 1 in 10,000, because that is the primary thing that we do for non-variceal bleeding too.
Is monotherapy today acceptable?
No, depending upon the forest criteria, depends on that. In case there is a visible vessel and bleeding like this, we'll first inject the adrenaline and then go for the clips. Second thing is that in case the visible vessel is not protruding, and if there is a clot, then obviously we are going to take out the clot, see if there is a visible vessel. Either if it is possible to put a clip, otherwise we can do a electrocoagulation by cooperative method, by putting a pressure and then either bipolar or multipolar, we can coagulate the vessel.
So I'll give you special situations. Massive bleed, nothing seen, high lesser curve, posterior wall of D1, all positions which are difficult for endoscopy. Are you happy to call your surgeon?
No, I will call IR now.
Is your surgeon happy to be called also? That's also equally important.
No, in case you have got an IR, I think the first thing is the IR.
So today, how many surgeons would like to touch these patients which are so-called difficult endoscopically, and how many of you all will be readily easy to pass it on to IR?
We always
Because
prefer-
data is there.
Yeah, you always prepare once an endoscopist has not visualized or seen the lesion where it is bleeding and what is the pathology. We are not. Our role is very minimal.
I think we should have a CT angiography first.
Yeah, okay. So this is a stage where we should touch these few investigations before you skip steps. Though the right answer is IR, because head-to-head IR is better than surgery, especially for regarding rebleeding patients, because these are all morbid patients. There are certain indications, of course, you are perforating duodenal ulcer, it's a different story altogether. Investigations, one of the surgeons, Madhya or whoever wants can take this.
Yeah, start with the basic investigation like ultrasonography, CT angio.
Yeah.
And
So ultrasonography, does it help you anything other than portal hypertension?
Portal hypertension. Yes,
So only thing is portal hypertension, otherwise ultrasound
Otherwise,
very
yes.
limited role. CT angio, CT 4-phase, extremely useful, especially with regards to ongoing bleeding, anything which is mid-gut bleeding, and especially with regarding to where nothing is seen. So it helps immediately to make decisions. MRI rarely used by us. Anything about RBC scans, Harish? Not in acute setup,
Not in
but
acute
maybe
setup.
in obscure
Maybe in
GI
obscure
bleed or
GI bleed you can use
in
it.
those kind of set. Any other investigations anyone is doing? For the sake of clinicians, we'll discuss a little bit about hematocrit, hemoglobin. Anybody wants to make a comment? So remember, hematocrit does not fall for first 24 to 72 hours. So don't believe the hematocrit which you see. And when you replace, remember there is hemodilution, therefore hematocrit becomes a good investigation. So if you have a hematocrit which is coming down, remember there is some hemodilution also involved. So these are few things which you should look at. It's an important investigation. One other investigation is BUN to creatinine ratio. It's a good marker, especially more than 30. It also helps. Quick imaging about coagulopathy and any role for PT-INR monitoring. Would you like to correct PT-INR? Do you chase PT-INRs?
Not in acute setting actually.
But would you otherwise like to
Yeah,
correct?
otherwise definitely. If it is
So
more than
remember, the
2.5
only problem with correction is that you need to know what you're correcting. Remember all vitamin K based antagonists which are used. In liver disease, it's important to know that procoagulants and anticoagulants are balancing each other. So if one value is up, usually the other value is low. Overcorrection does not help. Just a quick mention about tranexamic acid.
One more point, platelet count is also important.
Yeah. So, but that's so anything above 50,000 is good enough for gastroenterologists, because remember it is a quantitative reduction, it's not a qualitative reduction. The quality is still good. Any mention of tranexamic acid, pause silate, which is a favorite of surgeons and gastroenterologists? Does it do harm? It doesn't do good, that I know, but does it do harm?
Doesn't do harm.
So it does cause procoagulant state, and there is known to be thromboemboli phenomena. So it does cause harm. Do not blanketly give.
Yeah, DIC contraindicated.
So please be careful with this. Now these are pure endoscopy questions. And are you good enough? Which are the patient? Let me give it. So usually if you have anybody who is Forest 2B above, you probably require dual therapy. Forest 2C downwards, ideally you don't need therapy. You just need to look and come out. C's become B very easily with endoscopists, so just be a bit careful out there, because sometimes in making a C a B, you end up perforating and morbidity increase of these patients. Clips, I will ask you, difficult to place clips and any tricks in that. Whoever wants can take it. So let me leave posterior wall ulcer. I'll ask you simple questions. Posterior wall ulcers or high medial wall ulcers, both are very difficult. Superior wall, posterior inferior wall. So a little bit of people need to know about what is called a long stem and short stems. Sometimes space is not adequate, especially in D1. Often with ulcer disease, you get what is called a cicatrization, so positioning becomes a bit difficult. Superior wall, at times we have used the duodenoscope. Again, remember with clips it's a bit difficult, but use short stem. Basic answer is use short stems clips. They are usually relatively easier to place. Elevator load is a bit less. For posterior inferior walls also try and remember that, or go in for a modality which a very, very important modality remains saline adrenaline. We always say that it's a genuine lifesaver. Just simple question, what is the dilution for saline adrenaline and does it matter really? I know it's a foolish question, but still.
1 in 20,000.
1 in 9.
1 in 10,000.
So everybody is going to give, we can't have two different answers.
1 in 10. So you've already diluted.
1 in 10,000, half ampule of adrenaline, 10 cc of normal saline. Just please remember this. Why is this important? Harish?
I think so.
And does mortality matter?
Yes, that's important. Actually, the concentration increases, a small amount can be absorbed into the systemic circulation.
So remember,
and
anything
cause
which
problems.
increases the pressure head can cause. Vivekan sir, forest classification. Everybody talks about this, and why is it important?
Because that indicates the chances of rebleeding.
Yeah. So remember,
Most important.
natural process of non-varicial bleed is there is only 10% chance of rebleeding. Natural history of varicial bleeding is 60 to 80% chance of rebleeding. So there is an inherent difference between how you approach these patients. So please remember, even if you sleep at night.
Nitin here in the audience. Can I interrupt you regarding this clip? I just
तू
want
उशिरा
to-
आलास ना, आता शेवटचं बोल. किंवा वरती येऊन बोल.
Now, what is your experience of OTSC?
So remember, when you have a fibrotic ulcer, and OTSC becomes very, very difficult. Tethering this, trying to suck this in, or trying to pull it in usually creates more problems. And also, the vision is extremely obscured. So either you go in for an external system, star clip, padlock clip, in which the suction is relatively maintained, which still helps you, or else you go for areas in which it is relatively acute and friable. So if you have something which is not acute and friable, you will create difficulty. And we have some videos which we can touch later on. That time we'll take Uday's special. I'm going to ask this question to some initial attempts are not successful. What do you do? So you see two things I'll give you. Massive bleeding. You don't see only. You're seeing what you can do. You're trying to do what you want to do, but you're still not successful. 3 a.m. bleeder. Let's see this patient. When do you give up? Whom do you call? Do you call another endoscopist? Do you just intubate and wait? Do you just give medication and say, ki baguya udya sakai, if he survives, I'll have to do something?
So 3 a.m. when the entire world is sleeping and you're on the scope and you're seeing inside, and if you cannot see anything at all, I think so the best thing would be to, come out, try to do a stomach wash, lavage, intubate. The patient is definitely intubated that time, and go in for a second attempt later. Calling a repeat endoscopist, second endoscopist is your decision, because sometimes it can help, it may not help. The availability is important. But I think so if you cannot see anything because of residue, blood, it makes sense to, go again in at some point later.
How
Maybe
many are
after
in
an hour
favor
or
of blind injections, blind clipping, blind coag forceps, hold and try and pluck at 2-3 areas and see whether it stops?
Is it a varicial bleeding or non-varicial?
No, this is this patient, our patient. Okay, so we have very, very good experience now with hemostatic powder, and I think we have used it sufficiently well to realize that it's a game changer. So trust me, it may be 50,000 rupees for the ampule which you're opening, but if you ask me later on, I'll teach you how to reuse them, and we use it in 20-30 patients also. So we know how to retain that, keep the CO2 intact, use different catheters, but you can keep going with that powder because you don't need so much powder for one patient. But it's one game changer, and we should all realize how you can use it and have it as part of our armamentarium. Okay, so
Nitin, if you are not able to locate from where bleeding is,
So
how
what
can
I
you-
would do is probably look at resuscitation and CT angio. That will be my initial. In fact, I would have gone the other way around. If the Riles tube was full of fresh blood, I would have gone for CT angio first. In fact, try to localize where it is, because if I see it's an arterial spurter, I know it's going to be a futile attempt. Might as well use our services, because for us, interventional radiology is available around the clock. So it's not difficult for us. In smaller places, smaller centers, we can think. I want to touch on a few things which are very important here, and that is antiplatelets. And this probably, Dharamsi sir, I'll give you simple scenarios. I'll not complicate matters for you. This patient first we'll discuss, and then we'll pass on. Patient is on dual antiplatelets. Right now, what you'll do, post-procedure, what you'll do, you have seen that it's an ulcer bleed.
I'll wait at least for 7 days before considering.
No, what will stop? On day one, you have stopped everything?
We have stopped.
You have stopped in antiplatelets. If it were, suppose this is for secondary prophylaxis. Patient has had a stroke. Patient is on dual antiplatelets. This has ischemic heart disease, 2 stents in C2. How comfortable are you?
Start one antiplatelet.
May you continue one on day 0?
No, not 0. After you stop bleeding.
And how early after
48
bleeding?
hours after stopping.
So remember, though the questions are idiotic, the answer is that the half-life of platelets is 7 to 10 days. So the action is already in. So if you're using aspirin and clopidogrel, there is nothing to do. You can safely wait for 3 to 5 days. Reintroduce. What is your reintroduction of choice?
Aspirin.
So always remember it's aspirin, it's not clopidogrel. If it was on a DOAC,
Not sure of that answer.
you would have not started?
I'm not sure of the answer.
No, you are sure of the answer. You don't give it for 3 to 5 days, and ideally you avoid it. It's because the bleeding, there are no, so in simple words, there is no antidote. So you just have to wait through the half-life of platelets. Any experience with PCCs, platelet concentrates, platelet replacements, whole bloods, and any comments?
Yes, in case the PTINR is increased.
No, not PTI. This is for dual, for antidote to antiplatelets.
Antidote, okay.
So there is some data which is say that PCC replacements can be used, rarely used, and it is only in few of the DOACs where it is irreplaceable change, but we rarely use them. Any anticoagulants, what will you do? Patient with warfarin, Dr. Shivpujya?
Patient, we can stop warfarin immediately and start with the.
No, will you like to give vitamin K?
Yeah, vitamin K can be given.
Will you like to give FFP?
Not FFP, but plasma. FFP is it's better. Better is prothrombin concentrate.
Yeah, okay. Again, you can't do much because you've already given it. Vitamin K replacement is a good way of going about it. Give it 4 to 6 hours for it to act. That is the only thing which is there. Okay, our patient bled again within 24 hours, massive bleed, hypotension. Now what do I do? How many of us are insisting on a re-endoscopy? How many in the audience wants to do re-endoscopy? We have enough gastroenterologists out here. You wouldn't do re-endoscopy for a rebleed? I will do it.
We definitely will do second scopy.
Yeah, so why would we not do it? If we know that it's an ulcer which has bled, we have given him dual treatment, we have done all the resuscitation, patient has rebled, we will look at something else, and that something else could be your OTSC clip or could be something else which you can use. Harish, what would you like to do?
So
Will you like to skip the job and directly push?
No, I think so. Re-endoscopy will definitely mind it, but at that point of time, also I would definitely involve the IR immediately. Then.
So you have already done a CT angio. You know that there is no blush maybe in this patient.
Okay. So then re-endoscopy and look at the feasibility of OTSC.
Okay, I think this is a fair answer out here. And if there was a blush, would you like to have skipped the procedure?
No, but then if you have already located the site of bleeding, you need not have a blush. IR can be guided by just a clip.
That's also true. So my other question is equally important. If your patient is hemodynamically unstable, would a relook be required, or you'll skip your post and give it to the IR immediately?
I think so. If it's hemodynamically unstable, IR guide directly.
So IRs are game changers for most endoscopists. But remember, super selective cannulations, the availability of all instrumentation and accessories, and costing. These are few things which are, because it is an extremely expensive procedure. So it goes, at least in Pune, it goes to straight 1.5 to 2 lakh rupees. So we need to be a little bit careful. By what time will you involve relatives, families, and start discussing morbidity, mortalities in these patients? Dharamsi sir.
At the start of therapy, straight away.
Okay, but rebleed, what I meant is rebleed, what does it change? How does it change your outlook?
Yeah, the mortality is going to be high.
Yeah. So remember, in today's day and age, also in non-variceal bleedings, we are getting almost 10% mortality because most patients come with combined illnesses. So this is what we did in our patient. It was a posterior DU, fibrotic base. Clips were applied on day 1, rebled. We had placed hemospray, but still rebled. And in this patient, we went for a GDA embolization because we realized that this is not going to halt. Okay, now let's try and take a few cases here, and maybe we start with Vivekanand sir. Scope is put. So I'll tell you the background. This patient we had scoped 2 nights before. had just massive bleeding which was seen, but it was entire esophagus which was fired. No, sorry, I think, no, I'm sorry. This is a wrong patient. Okay, I'll rephrase this. This is what is seen in this. This is not this patient. This is another patient. This is a patient who, known case of chronic liver disease, has come with a massive GI bleed. We had put in a scope, and this is what we see.
Well,
No varices seen. Patient was intubated already. Patient is in supine position. Therefore, a lot of pooling is there by gravity because we wanted to pick up this one, and this is what we are seeing.
this is not on the collapse varix. This particular
It is a
picture.
varix.
It's
It is a
varix.
nipple on a varix.
Yeah, it's a varix.
Yeah.
Yeah, I will put a band.
On this,
Yes.
any difference of opinion? No, this is esophagus.
No, glue is the treatment of the choice. Glue.
This is the G junction.
Glue.
This is just about G junction.
Glue.
Glue.
We have put bands on this.
It's already been banded in the past. The patient has come with a bleed separate from this episode. Just come with a GI bleed.
But this is a different site. From the
I
previous
don't
banding.
know. It was banded by somebody else. I just put in the scope. This is what I saw. So we have 4 answers from 4 gastro.
Ideally both. First put a glue and then band the above.
So with band, the only worry here is that the way the varix looks out here, it looks quite that only the vessel is exposed. There's hardly any varix which is left on it. And that's why the sucking becomes a bit difficult. Would any surgeon like to take this patient?
Glue in the feeding vessel should work here.
Okay, so this is what we did. We just couldn't see anything. Every time we attempted to do anything, we just couldn't see. How many of y'all were at this stage wanting to involve IR and go in for an emergency tips? Okay, so what we did was we placed in an ELA stent in this patient. We just wanted to buy some time in this patient. We had already started prepping for getting into with an IR, but this is what we did. Any experience with ELA stents? So we have quite a lot of experience. Works in 2 out of 5. 3 of them will die. Okay, so because there's nothing you can do. Little bit cumbersome, the older ELAs, the newer ones which are without balloon are like an esophageal stent, easy to deploy. If we get good space above the ELA stent, we put in a clip onto the removal, the pulling loop, the pulley which is there we put, because migration remains a problem. But the diameter usually ensures it stays. Idea is 3 to 5 days. Any experience, or has everyone forgotten SB tubes?
That's what I was going to
And
tell
I
you.
think it's one thing which will really save you, not in this patient because here the vessel is absolutely exposed. The basic aim is to blow up the fundus with about 150 to 200 saline, because remember the perforators flow away from the cardia, both above and downwards. If you take the perforators, you have taken the patient. So always remember the pressure is kept out there.
But with a balloon, I think there will be more chances of aspiration. We are blocking the esophagus. With elastant, I think the esophagus will be
There's a
open.
port which sucks out all the fluid above the
No, but then-
above the balloon.
Okay, so one second, I'm not too sure what patients are what. This is the same patient. Just 1 second, guys. I just want to see what is where. I'm sorry about this. I think this is the one. Okay, so this is another patient. I want somebody's opinion on this. Known case of CS stomach, 4 episodes of massive hematemesis. Scope is put in, and this is what you see. Anybody has any comment? You see I'll tell you what it is. It's an incisoral growth which is there, mainly along the lesser curve, high with complete bleeding, large clot which is formed on top of it. Options.
Hemospray is the ideal option.
Hemostasis powder.
Hemostasis powder, IR, or surgery.
IR rarely works in this because there are multiple feeders usually. Any mention about hemostatic radiation, and that's a big play for us. We do low dose radiation, so that is also a good way of going about it. But when patient is actively bleeding, please look at hemospray, have it. Do not use the cheap one which is available, it doesn't work. Remember that this is a polystarch which helps, and wonderful results. For whoever has used it, has really helped. So this is one. Okay, this is that patient which I was telling you, bled 2 days before. We put in a scope, had erosive hemorrhagic esophagitis, but we weren't convinced because HB was still falling. This is 48 hours later, that heraldscopy. We put in a scope, we see that there is esophagitis, and this is what we see. Now what do you do? Nothing is seen, just blood. Dharamsi sir, we intubated this patient at this. I'll tell you what we did. We intubated a patient, started organizing for research. A patient has come from the liver ICU. This is a chronic liver disease patient. I'll give you a little bit of caveat. If I give you the history, you'll all diagnose it within 1 second. But so this patient is waiting for transplant, developed a massive GI bleed, was in hospital for almost 3 weeks prior to that, had an episode of pancreatitis, which was there about 3 weeks ago. Came with bleeding, had small varices in the heraldscopy which was done. We saw extensive esophagitis. When we put in the scope, this was what was going on. What would you like to do?
Probably
Patient is in left lateral position in this case.
Probably a duodenal varix.
So what we did was, we did blind injections first. And it works. So it's not because we had certain idea. This patient was scoped 48 hours before and the duodenum was clean. There was nothing in the duodenum. So this was scoped by us, so we knew that we are not dealing with it. We thought it was a stress ulcer. So this is what we did. We injected this patient.
With what?
Saline adrenaline. And, sorry, I just got my, and this is what we went for next. And were we justified, were we not justified? And I think what has happened is I've missed one video in between. There was a big hole with severe protruding blood from there. So this was what there was a hole, there was a rent in the duodenum with just blood oozing out from behind. So what, at that stage, we possibly were thinking about two things. What would you have thought? So this was the antero-superior, and there was continuous bleeding which was coming. What we did was we placed 3 clips. Luckily, we got some space out there, some time we got out there. We did halt the bleeding. So this is the same patient who was bleeding massively at that stage. We put hemospray out here and we came out. Anything anyone would have done differently? Would you have liked to operate this patient? Chronic liver disease, decompensated, child C, going for surgery.
IR maybe.
Sorry?
IR.
Okay. So we listened to your advice. We did a CT angio. It was a bleeding pseudoaneurysm which was there behind. So it had burst through and the entire vessel had come through. So we went, we had a dual packing which was done, the superior duodenal artery, the PDA also, as well as the GDA. Both were taken by us. There were 2 pseudoaneurysms.
Just a comment. We could see the points, that's why it's okay, but I would have also put a EOS scope if we had not identified.
There was just too much blood. It was out of question to try and attempt at this stage.
No,
because
that's the problem. When there's blood,
yeah.
EOS can identify.
No, the problem here, Siddharth, was not that. Just the morbidity, hypotension involved did not let us think. We thought of what was easier. In hindsight, yes, pseudoaneurysm, we should have thought about it. But I have very strong opinion about this because even if you identify a perforator and a vessel or a pseudoaneurysm, you believe your coils are in the right place, but you are looking at 2 dimensions. The IR looks in 3 dimensions because they have got much better subtracting value. And very often we have misplaced coils. So we show only the ones we are successful in. But in a lot of them we have displaced coils. So please remember that this does happen.
But you are lucky that your blind injection worked.
So sometimes just being basic works. So ladies and gentlemen, I don't want to summarize this, it's just okay. Just a few things with regard, we are not touching variceal bleeds, happily for everybody. Just what has changed, little bit of points which I want to know. One is, do not resuscitate more than necessary. Crystalloids are good enough. Ringer lactate works well. Give blood transfusions only between 7 and 8 grams. Do not over-perfuse your patients. triage well, decide who needs emergencies, sometimes emergency skills, have your people on board, have technicians, anesthetists always. There is no problem in intubating. A little bit of overcorrection is also okay. Look at your primary endoscopy. Anything in forest, first 2-3 stages, try and go for dual therapy. Having failed, keep the next guy ready. Usually it is the IR. Unfortunately, surgeon is rarely required, but surgeon is required at times. So it's not that way. Have a team approach, and all the best for everyone.
Any questions? Any questions from the floor?
Let's have it at lunchtime,
Oh,
so that I am not there and others can answer.
One question from
panel side.
panel side.
Ask
in
panelist.
last- in
Ask panelist.
In last 5 years, which are the patients you have referred for surgeon?
For surgery directly?
Yeah.
As a rule in life, no virgin is ever given to the surgeons.
We have been called here.
It depends
I asked
on
the same question.
I think it depends on the facility which is available in that setup.
No, but wherever there may not be facilities, still try and search for an endoscopist, because at least in this bleeding today, the roles have reversed.
Okay.
And they will happily agree that roles have reversed.
Yeah. Okay, very nice.
Thank you, ladies and
discussion,
gentlemen.
Panel discussion. And we'll end up with the session felicitating Dr. Nitin Pai. I request moderators to felicitate Dr. Nitin Pai. Thank you. I request Dr. Vishal Akude to felicitate our moderators. Dr. Vivekanand Kulkarni, Dr. Harish Peshwe, Dr. Deepak Patil, Dr. Vijay Shivpuje, Dr. Vaibhav Mudhale, and Dr. Dharamsi sir. Thank you, moderators. Thank you, Dr. Vishal. Now there will be like.
Now we move on to the next symposium on perianal diseases. It's a lecture on perianal diseases by Dr. Amol Pavaskar, Sawantwadi. The chairpersons for this session are Dr. Jeevan Lahoti from Satara, Dr. Madhura Killedar, Professor of Surgery, Bharati Medical College and Hospital, Sangli, Dr. Chaitanya Bokil, Satara, Dr. Pramod Rajbhoi, Maini, Satara, and Dr. Sandeep Sawant, Karad. Dr. Sandeep Sawant from Karad. Dr. Pradeep Patil. Dr. Sandeep Patil from Karad, sir. Dr. Sandeep Patil. Dr. Sandeep Sawant, please, to come on the stage. Dr. Sandeep Sawant from Kankavali. Sorry.
Hello, good morning, friends. At the outset, I thank the organizing committee of this conference to giving me the opportunity. I know after listening to hi-fi lectures in technology and all the gadgets in hemostasis, this is an extremely common topic, but across all specialties, we see patients with common perianal diseases. Though they are deceptively minor problems, but if you want to give good results, it really demands perfect anatomical knowledge, precise diagnosis of the problem, immaculate planning in choosing a correct option for that particular patient, tailor-made approach, and it requires finesse in procedural execution. Otherwise, recurrences and complications are not far off. So, I know this audience is exclusive and elite audience, plus in next 30 minutes, I will try my best to overview beyond obvious in surgical strategies, evolving options, evolving techniques, and small decisions which will change the course of the patient. So before talking on perianal diseases, we cannot skip knowing about the anatomy. Just revising through anatomy is very important. All of us know anal canal is developed embryologically from hindgut, that is a endodermal component, and anal pit, which is an ectodermal component, and this is the transitional zone. The mucosa above is a columnar mucosa, and below the level of dentate line, it is a squamo-columnar to stratified squamous epithelium. And for all convenience, we divide anal canal into surgical anal canal, which extends from anorectal ring to anal verge, and anatomical anal canal from dentate line to anal verge, and which is divided by white line of Hilton, which just denotes the end of the internal sphincters. This anoderm has speciality that it doesn't have sebaceous glands and sweat gland. That is how it differs from the skin beyond anal verge. And all of us know there are anal papillae. These are just mucosal folds, valves-like thing, which are also called anal valves. The recesses behind the anal walls are anal crypts of Morgagni. And the columns which are formed by anal cushions, which is nothing but scaffolding with the hemorrhoidal vessels, these are columns of Morgagni, and which play an important role in continence. So when we talk of the muscles, we know the circular muscle fiber of the rectum continues down as internal sphincter, which is not more than 3 millimeter wide, and which is supplied by, it is an involuntary smooth muscle. While external sphincter is nothing but continuation of puborectalis sling, which is a part of a levator ani or a pelvic diaphragm, which is formed by puborectalis, pubococcygeus and ileococcygeus. And this is a voluntary sphincter, which is for convenience divided into the deep, superficial and subcutaneous part of the external sphincter. So it is a voluntary sphincter, skeletal muscle sphincter. And the longitudinal muscles of the rectum joins with the endopelvic fascia of levator ani and continues down in the intersphincteric plane as Park's ligament, all of us know. At the lower end of the internal sphincter, it splits into 3. The medial is called, it gets inserted at the white line of Hilton. The lateral septum goes laterally to divide perianal space from ischiorectal fossa, that is called as a Milligan septum, and it gets inserted into the pudendal canal, all of us know, that is also called as the Alcock's canal. And the lower fragments the subcutaneous part of the external sphincter, and that gives rise to corrugator ani, which is a muscular attachment to the skin. As far as the blood supply goes, all of us know the arterial supply is from the systemic circulation, but the venous drainage above dentate line goes to portal circulation, and below the level of dentate line, it goes to the systemic circulation through inferior rectal veins. The nerve supply above the dentate line comes from autonomic nervous system, lumbar sympathetic plexus and nerva erigentis, and the lower part is supplied again by the somatic innervation. So the pain sensation is only below the level of the dentate line. That is the region fissures are painful. And this is just the diagram of the pelvic diaphragm. So though this may appear inappropriate for this crowd talking of digital rectal examination, I just want to illustrate few important points. All of us do DRE in every day in and out, but we have to be extremely systematic whenever we approach a patient for digital rectal examination or for rectal examination with our inspection. Then anal wink we must elicit to identify anocutaneous reflex. It tells you about L1, L2 integrity. And when we put our finger inside, besides looking for luminal in the wall and outside lumen pathologies like prostate and vagina, the most important thing, we should make an attempt to look for a clinical anal manometry, which we don't give adequate time. The pressure resistance at rest tells you about the internal sphincter integrity. If you ask the patient to squeeze and hold around your finger, that gives you a fair idea about external sphincter. And if you ask the patient to expel your finger, that gives you an exact idea about the defecation pressure, or what we call as the anal pressure. And if you put your finger behind to palpate for the anorectal shelf, which is nothing but levator ani, anorectal ring, and with the forward and backward movement during the process of defecation or deferring defecation, that gives a fair idea about anal manometry without MRI defecation grams, which are costly and not available in mofussil areas. So all of us know hemorrhoids are not really problems of the vessels, but is a problem of the anal cushions, as I told you. And these are just the fibrofatty scaffoldings in columns of Morgagni, which support the artery and vein. An important part in anal cushions in hemorrhoids is the local inflammatory process because of microvascular shunting. And there is a capillary leakage because of the increased blood flow and increased venous flow. And this is the main pathological process. So breakdown of anal cushion is the pathogenic process in formation of hemorrhoids. We all of us know this Gallagher grading, but what we forget is we also have to mention the circumferential extent of the hemorrhoids in our grading. Whenever we mention 1, we should say 1A, B, or C. A means a solitary hemorrhoid, B is less than 50%, and C is more than 50% involvement of the circumference. And mentioning about external hemorrhoids, whether they are present or not, this is just for a proper reporting and informing the other consultant. When we talk of hemorrhoids, we cannot forget we have to differentiate between rectal varices and hemorrhoids, because the treatment changes. Rectal varices are essentially, rectal varices are basically located above the level of Hilton's line. They are essentially only venous. There is no anal cushions are not defective. They do not prolapse in proctoscope like hemorrhoids. They are thin, tortuous, bluish veins, and when they bleed dark red and not bright red like hemorrhoids. And treatment, all of us know it's treatment of portal hypertension with or without banding, or whatever for the variceal treatment we do. The same way we treat rectal varices. In subset of patient of hemorrhoids with age more than 50, or those who are more than 40, but with a first degree, one relative with CRC, colorectal carcinoma, or 2 relatives with benign adenomas, requires colonoscopy. If not, at least a flex sigmoidoscopy. We know what lifestyle changes causes hemorrhoids. The first thing before embarking on any surgical procedure or treatment, the first thing is to correct the lifestyle. Second is the liberal use of laxatives. The word of caution, don't use bulk forming laxatives in perianal diseases. What is preferred is either osmotic laxative or stimulant laxative or lubricant laxatives. And MPFA, micronized purified flavonoid fraction. These are the flavonotics group of drugs which have a significant role in acute hemorrhoidal crisis. The drugs like calcium dobicelate or something like Daphlon or Rutocide, they do wonders in patient with acute hemorrhageal crisis and even in preoperative and postoperative treatment. But the dose is 1000 milligram 3 times daily for first 4 days, followed by 1000 milligram TDS or 3 times daily for next 2 days and 1000 milligram OD for at least 2 months, but it works wonders. If you are using calcium dobicelate, patient can get agranulocytosis. You should be careful about it. Beyond this, then it comes what are the modalities of treatment you are going to use. For early grading, definitely there is a role for sclerotherapy, but the agents have changed. Now no more we use phenolene almond oil or sodium tetradecyl sulfate or alcohol is no more used. The preferred one is a foam sclerotherapy with polydoquinol 3% and foam, that is a Tessari technique, what is called as. You take 2 ml of polydoquinol 3% with 8 ml of air and inject at the hemorrhoids. And Barron's band ligation has been replaced with now multi-ligator like variceal banding with a suction device. We used to use forceps to pull hemorrhoids, but that is not used. Some people use both combined together, Barron's with sclerotherapy. Various energy sources have been attempted to take care of hemorrhoids for causing fibrosis, infrared photocoagulation, and radiofrequency ablation, which is commonly practiced in Italy. But the most preferred nowadays is hemorrhoidal artery ligation, whether it is digitally guided or Doppler guided, finger guided or Doppler guided. And along with that, we can do something called as a recto-anal repair. It is a type of a hemorrhoidopexy. You take suture in the submucous plane to just obliterate without excision. And the new technique is coming as something called as embroidery. This is from a French group who was started in 2014. This is like interventional radiologist is involved to embolize superior rectal artery in acute hemorrhoidal bleeding in an unfit patient. Nowadays, patients are demanding for lasers in almost every situation. Patients ask whether you have got a laser facility, and which are commonly used as one of the energy source to take care of hemorrhoids. This is a 1470 nanometer diode laser, but we have to use conical fiber in a pulse manner, 6 watt per millimeter per second. The entire energy should not cross 150 joules at a time, and it should be given in a fan-shaped manner without injuring. But laser alone doesn't work. It has to be combined as a hybrid technique along with the hemorrhoidal artery ligation at the top. When it comes to surgery, in spite of all the advances in energy sources, time-tested method for grade 3 and grade 4 and complicated hemorrhoid is still Milligan-Morgan's hemorrhoidectomy, open technique, which has been practiced for last 80, 90, 100 years, and still maybe it is one of the commonest surgeries still done for hemorrhoids. You can close like a Ferguson's technique, and in certain subset of patients where there is a prolapse with hemorrhoids, you can combine a stapler hemorrhoidopexy, which is also called as a procedure for prolapse hemorrhoids, PPH. But because of the high recurrence rate, this is not popular nowadays. The economical option for stapler is Chiute's hemorrhoidopexy. I mean, it is slightly technically demanding, but as good as serves the same purpose like a stapler hemorrhoido. It takes care of hemorrhoids as well as the prolapse. And in the common problem when we excise primary hemorrhoids, what to do about the hemorrhoids remaining in between areas. And for them, the technique is U-stage hemorrhoidopexy, or as I told you, recto-anal repair. Commonest and most painful disease of the perianal diseases is anal fissure. All of us know it's a positive feedback cycle of microtrauma, tear because of straining at defecation, which leads to pain, spasm. Then that reduces the perfusion to the mucosa and poor healing. And this cycle continues from acute fissure to development of a chronic fissure, which is depicted by hypertrophied anal papilla, fibrous edges, and a sentinel tag or a skin tag. Of all the drugs which are available for relaxation of the sphincters, diltiazem and nifedipine scores over glyceryl trinitrate because of the headache and poor tolerance of JTN. Some people prefer sucralfate gel with or without metrogel. or nitric oxide nanoparticles. Botulinum toxin injections gives excellent results, but there is a chance of recurrence after 3 or 4 months. Now, even EMG guided doses injection exactly at the internal sphincter, at the spasmodic sphincter is practiced, and even availability of botulinum toxic topical gel is in the available. The emerging therapies are platelet-rich plasma injection, regenerative therapy, stem cells, and hyaluronic acid suppositories. But still, they are not available for our group of patients. The most important point whenever we are managing chronic fissure is we must know the anal tone with the anal fissure. Either with your clinical manometry or you do a proper defecation or anal manometry. If the pressure is high, only and only then the surgical techniques like sphincterotomy, whether it's a closed sphincterotomy, lateral subcutaneous sphincterotomy, or open sphincterotomy works. If the anal tone is normal or low, then CLS doesn't work. Closed lateral sphincterotomy doesn't work. What we have to do is excision of the fissure called as fissurectomy, and the wound is covered with either a mucosal advancement flaps or island flaps. But definitely the role of Rickham ears or anal dilatation and uncontrolled stretching of the internal sphincter is no more done. Some people still use anal calibrator for females up to 35 millimeter and gents up to males up to 40 millimeter. But it's an uncontrolled dilatation. It should be discouraged for the sake of incontinence. Perianal abscess is acute presentation, and perianal fistula is chronic presentation of the same pathological process called as cryptoglandular infection. It's an infection of the anal glands which are situated in anal crypts. There are 6 to 8 anal glands normally which open at anal crypts, and they are located either submucous, intersphincteric, or extrasphincteric. So all of us know these types of anal abscesses classification: the submucous, superficial perianal, istiorectal, intersphincteric, supralevator, infralevator, and pelvic abscess. But what we forget are the posterior spaces. We should not miss out abscesses in this location. Above the anococcygeal ligament is a post-anal, deep post-anal space. Above the pelvic diaphragm is supralevator space. Behind the rector is retrorectal space. These are the abscesses. These locations are difficult to diagnose clinically. You might require MRI or some investigations to pick them up at an early stage. There is some paradigm shift in management of perianal abscess. First thing, we must make an attempt, active attempt, to identify infected anal glands at the time of abscess drainage, and if at all, treat them either with fistulotomy or set-on. Second thing, all the abscesses medial to external sphincter we should drain it from inside, and all the abscesses lateral to external sphincter should be drained outside. And in istiorectal abscesses, we must be knowing it is not only istiorectal abscess which becomes horseshoe. There is a horseshoe space even in intersphincteric abscess and even in suprasphincteric abscess. So we know the classification. I'm not going into the detail. Everyone here knows about this Disperse classification. Either the fistula is simple, that means a low fistula up to the low transsphincteric, and complex is the higher fistulas. The most challenging thing in fistula treatment is identification of inner opening at dentate line. 90% of the time it is at the dentate line. So pre-operatively, we should make all the efforts to do with investigations like MRI fistulogram, properly reported MRI, that is more important. Just doing MRI has no meaning. It should be reported with St. James University classification and with a picture from a radiologist, where is the internal opening. Otherwise, it is difficult to locate. If you have a facility of endoanal ultrasound, it can give you a correct idea. But sometimes it is not even possible in spite of even use of AI with MRI for internal opening identification. Intraoperative, we can try with this, all of us try methylene blue injection with a drop of hydrogen peroxide. We can intubate the fistula, that can give us a fair idea. If you have availability of a VAP, that is a fistuloscope, that helps in identification of inner opening. If in spite of all this, there are cases we cannot, then we can guess the fissular inner opening with the help of Goodsal's rule, age-old Goodsal's rule. I'm not going to tell it, everyone knows it. And something called as a GARC protocol. GARC protocol is when you, with all the efforts you cannot identify, you dissect the external tract till you can dissect, and then whatever the closest position of the dentate line to the inside dissection, you just assume that there is an inner opening and you can treat it as an inner opening. My personal favorite, if nothing works, the best thing is to dissect the external tract and pull the tract and watch at the dentate line with a small scope in the anal speculum. So you get a traction feeling where there is an inner opening. And second trick is you take saline and inject a dentate line. The part at the internal opening doesn't get elevated. That is another clue that there might be internal opening. But we should make maximum effort to identify it. If not, be prepared for at least 50 to 70% recurrence of fistula, whatever way you treat. All the simple fistula, meaning superficial fistula, intrasphincteric fistula, and transphincteric fistula involving less than 30% of the external sphincter can be treated with age-old Park's fistulectomy, with or without sphincter reconstruction, with or without marsupialization of the wounds for early healing. But beyond this, whenever it comes to complex fistula, the age-old method like setons really keeps you away from embarrassment of recurrence or sphincter damage. So either they can be draining setons, which are the most popular one, rather than cutting setons, and chemical setons are the monofilaments impregnated with various materials with the optimism that wishful thinking that the fistula will heal as well as it will cut through the fistula, like a thread cutting through the ice, something like that. The same principle works in fistula. But an age-old Kshara Sutra was used as by Ayurvedic practitioner as a complete treatment of fistula, which was a linen thread impregnated with chemical from Ayurveda like Kshark, Shira, and Haridra, I think. They are the chemicals which was used, maybe some different, but that works wonders. And now the setons are loaded with antibiotics, some regenerative materials and growth factors. Instead of polyfilament, we prefer a monofilament. Or sometimes you can use tags like whatever we get at airport. Those also can be used for cutting setons or draining setons. But we try to take an incision on the skin so that the cutting tissue becomes limited. WAPT, we know it's a small, tiny, thin scope, 3.5 to 4.7 millimeter diameter and 18 millimeter long scope with its 2 millimeter grasper, and various energy sources like electric. You can use laser fibers along with that for treatment of the fistula. Basic principles you see, curate and ablate the tract with the energy source. In cases of recurrent fistulas or inner opening when you want to manage in complicated fistula, mucosal advancement flap, rectal advancement flaps works wonders. But the most promising technique in today's era is ligation of intrasphincteric tract, where at the intrasphincteric area we dissect, we identify the tract, we cut it and transfix both the edges. But only lift alone doesn't work. It has to be combined with treatment of inner opening, with whatever mucosal treatment, and treatment of the external tract from external sphincter to the external opening. It can be treated with various options and various energy sources. Occlusive therapy has been attempted for long in fistula treatment, again with the optimism that it may heal with something like a stem cell therapy, platelet-rich plasma. Fibrin was the age-old, which was used with scaffolds. Bioabsorbable collagen plugs with umbrella pattern. So various things are tried to put in the fistula tract and expect that it will heal. Fistulizing Crohn's, in spite of all efficient medical step-up treatment and biologicals available, dealing with these patients is extremely challenging because it needs minimal surgical intervention. In simple fistulas, we can treat with fistulotomy, but in complex fistula like this,
may require come down to the defunctioning stoma, or sometimes in few cases proctectomy with even permanent diversion. So these are most difficult cases to treat. And the last segment of my lecture is about pylonida. Pilus is here and nidus is the nest. All of us know there are primary sinus and secondary sinus. But now research has proved that pilonidal sinus is the outcome of hook-shaped hairs which pierce soft, vulnerable post-anal skin, forming primary sinus, and these hairs and the abscess exit through multiple or single secondary sinus. So that is the basic pathogenic process. So we have to treat these epithelial tracts and eliminate this entire sinus with the abscess cavity. That is the principle of treatment. So the challenge in pilonidal sinus is after wide excision is not a challenge. Challenge is how to close that big defect. If we close it in midline, it is doomed to fail. 100% it is going to fail. So purpose is we have to avoid midline closure and we have to eliminate the internatal cleft. That is the purpose of all the methods which has been developed. So with the advent for earlier healing and better healing, lot of things have been utilized, either as marsupialization, like a Scandinavian technique, we suture skin to the underlying periosteum. Secondly, we can use VAC, negative pressure therapy, in a large wounds. PRP, platelet-rich plasma stem cell gels have been attempted, and silver dressing, nanoparticles, antibacterial sutures, a lot of things have been tried. But when you cannot do this and you want early recovery, the best thing is to go for these flaps. Various flaps have been described. Of everybody else has different preferences. My personal preference is Lemberg rhomboid flap. That gives excellent results and not very difficult to technically also demanding. But whenever, now in the area of minimally invasive methods, we don't want to exercise and we want to treat the tract with the help of various gadgets available, like fistula. So the primary purpose, we have to get a epithelial tract at the primary and secondary sinuses out, and that is best done with a skin biopsy forceps, which is called as a trephining the tract. And once you make a trephine at multiple tracts, clean the tract, and then whatever the sinus is, they are loaded with hairs and abscess, that is curated off, and then the sinus can be eliminated with either electrical energy source, or you can use laser energy source, or combine them. Hybrid techniques are used. The best technique to use is phenol, crystalline phenol. The once it comes with contact of body temperature, it becomes liquid phenol. Even 40% phenol is an extremely effective treatment. No need of pilonidal sinus scopes or hi-fi gadgets for all this. So certain pulse I just want to mention before concluding. One about the seeds bath. The seeds bath should not have potassium permanganate or betadine. The temperature should not exceed 40 degrees centigrade, and it should not be for not more than 15-20 minutes. Laxative I talked about. Methylene blue 1% with 0.25% bupivacaine is an excellent local analgesic in a post-operative period. If the patient has a severe pain, you can infiltrate it subdermally. Hyaluronidase has a big role in the circumferential hemorrhoids, grade C or grade D circumferential hemorrhoid, because it reduces the excision of the skin and further anal stenosis. Anticoagulation has been just talked about, so I will skip, but we have to be careful in Hess bled patient. This is a mnemonic for high-risk patients in anticoagulation. If patient is recently gone through a cardiac thing, all of us know we have to have a switch therapy with heparin and stop warfarin and double antiplatelet. Gut microbiome has a definite role in perianal diseases. See, we had excellent talk from Dr. Vaishali Gayakwad. With the evolution in artificial intelligence from basic algorithms to the deep learning and decoding human subjectivity, now none of the medical field is away from artificial intelligence. So in perianal diseases, it helps in wound tracking, telecommunication, online education, inner opening identification, and classification of fistula. So just to conclude, all perianal problems are not piles. All hemorrhoids are not primary. Perianal abscess needs early drainage with definite goal of prevention of fistula. Fistula management needs optimum aggression and restraint to prevent recurrence as well as prevent incontinence. And majority perianal elements need tailor-made anatomical cafeteria approach. When you have got lot of thinner and thinner endoscope and evolution in energy sources, what we have to, the most difficult task is to choose which is the best for your particular A number of patients. So, good set of bowels is worth more to a man than any quality of brains. And this is the quoting from Johns Billings. He identified in 1818. Thank you very much.
So can you highlight about the inflammatory conditions in the anal canal proctitis like thing?
See, perianal disease is a huge topic of the entire conference. So 20, 30 minutes it is, but I have not talked of anal pruritus, lot of conditions which are under anal pruritus. The main important treatment for anal pruritus is improvement of the hygiene, taking care of the local discharges, and preventing unconventional therapies for perianal conditions. The common cause of anal pruritus is because of application of steroid-containing ointments, and which is instead of applying to the anal canal, it is applied to the perianal skin. That is one of the common cause. The local hygienic factors like in incontinent patient or because of sentinel pile, there are some discharges which give rise to anal pruritus. The best treatment is try with anal, all the antihistaminics and treat the underlying cause.
Okay. Very nice lecture, and you have elaborated very nicely. It recalled the MBBS times when we listening to
It was a very basic
Yeah,
thing.
very nice. Any questions
Dr.
from the
Pavaskar, you said potassium permanganate and betadine should be avoided in sitz bath.
Yes, sir.
Why?
See, the sitz bath, the importance of sitz bath is not for the antisepsis, first thing. Secondly, sitz bath is given to the perianal skin rather than the anal canal per se. So its importance is it gives a local warmth, it increases local blood flow and helps in healing and alleviation of the pain factor. The potassium permanganate and betadine, what you gives a reaction in the same as Madam mentioned
Yes,
about the
yes.
perian.
It
If you
causes
see the
staining.
patient, they come with all geographic map around the anal canal with potassium. And it is recommended, it should not be for 45 minutes and 1 hour. It should not be more than 15 to 20 minutes because the mode of action is not antisepsis.
Yes.
It is just cleaning. You clean the perianal area and give a hot, warm bath, not hot, warm bath, so that local inflammatory process is hastened. So healing is
In few of the fistula cases, we can recommend with betadine. When we
No, that doesn't take away the responsibility of cleaning the fistula
Yeah,
wound.
it's there,
That is
yeah.
the responsibility of the surgeon
Yeah.
who does it, not the patient. Post fistula, if there is a big wound,
Yeah.
we personally or our assistant has to clean it nicely, and hot bath is not for that actually.
Yes.
Dr. Parvez Sheikh says that sitz bath is not necessary. You can just use shower.
Yeah, it's
Morning and evening.
anything which
It is not mandatory, but
increases
if
the
at all, it
local
should not be
temperature.
added with any chemicals. That is fine. Temperature has to be guarded.
Yes.
Now there are some automatic sitz bath machines have come.
Yeah, very
Like
nice.
a spray, the
Yeah.
machines, they give a sprinkler like thing and you get a warm bath.
They are very nice.
They
are
can kept on
designed-
a commode, plastic, you get like a tub thing. With automated one, the timer fitted into it.
Okay, thank you, sir.
Moderators to felicitate Dr. Pavaskar with a bouquet. I request Dr. Abhay Devekar, Senior Surgeon from Mirrors, to felicitate moderators. Moderators, please be on the stage. Dr. Sandeep Sawant, Dr. Madhura Killedar, Dr. Chaitanya Bokil, Dr. Rajbhoi, and Dr. Jeevan Lahoti. Thank you, everybody. Now the next lecture is Foreign Bodies in GI by Dr. Sanjeev Chatni, Hubli. And the chairpersons for this session are Dr. Charuhas Bhagwat from Kolhapur, Dr. Prasad Pujari, Miraj, Dr. Saurabh Kulkarni, Kolhapur, Dr. Vishal Akode, Miraj. Dr. Prasad Pujari.
Yeah, thank you. And
Dr. Saurabh from Kolhapur.
Thank you. At the outset, I would like to thank the organizers of DSG conference at Sangli and for inviting me and for the great hospitality. What I'm going to do in the next few minutes is to take you to the journey of what we experienced in removing upper GI foreign bodies. So, as you know, children form majority of the foreign body ingestion, that is upper GI. They account to around 80%. And the most frequently ingested foreign bodies, as mentioned here, that they could be coins, toys, magnets, batteries, and pins. And most foreign body ingestion in adults occur while eating, leading to either denture or bone or meat impaction. Sometimes these foreign body ingestion could be suicidal in adults also. And flexible endoscopy is a therapeutic method with a success rate as high as 95%. So when we classify a foreign body, they are basically classified into either blunt, sharp-pointed, long objects, food bolus, and others. Others is like what we see in airports and other places where drugs are taken in packets, either in rectum or they are swallowed. So what are the indication of foreign body removal? It all depends upon how emergent or how urgent we have to remove it. So if it is a sharp pointed object, we have to remove it immediately. It could be needle, toothpick, bone, safety pin, dentures, etc. And another indication for emergent foreign body removal is whenever there is acute esophageal obstruction, that is food bolus has obstructed and patient is vomiting, not able to even take in the saliva also, and button batteries, most common emergent indications for removal of foreign body. Non-emergent indications could be blunt objects like coins, buttons, or small toys. So what is when a patient comes or brought to OPD or casualty, first is we have to just get a plain X-ray of the chest and abdomen. Sometimes CT is superior because what we have seen is that sometimes the foreign body is there in stomach. And then when the X-ray is taken, it appears that it has gone down. Very difficult to localize in X-ray. During that time, best is to get a CT to localize. And timing is very important. It is dictated by the perceived risk of aspiration and or perforation. And urgent endoscopy, as I have mentioned, should be done in sharp objects, disc batteries, which are lodged into the esophagus or stomach. So, do we sedate all patients? Definitely yes. Conscious sedation in case of adults, while for children, it has to be endotracheal intubation. Airway has to be secured. And we know that these are some of the instruments which we need to have it in our endoscopy suits. That is grasping forceps, polypectomy snares, over tubes, transparent transparent cap fitting devices, etc. And this has been highlighted in this photo here. And when do we send a patient for surgery in case of foreign body ingestion? If it is battery ingestion and if it has failed to pass in 48 hours, then if there is narcotic packets ingestion, or if it is a sharp object where endoscopic removal is not possible, or object has not moved in 72 hours, that is 3 days, or if it is advancing with a pointed end. So this is very important. So kindly involve the surgeon in such scenario. So what I'm going to do in the next few slides is to share my experiences at our local place, what foreign bodies we have removed. This case was referred to us, and we have done this in not a very ideal scenario, not a very bookish picture, but what the end point was that they were all successfully removed. So this patient was referred as odynophagia, and it was another endoscopist or a surgeon attempted at local place where they found there is a food particle which was stuck above. So they thought it is CA esophagus. So this was a foreign body. When they came to me, there was no food bolus impaction. So this is, in our language, we call it as jali mold, that is V-shaped, sorry. That was a V shape of the thorn which has got pierced inside. So could just hold it with rat tooth forceps and remove it without any perforation at the upper esophageal sphincter. So that is how it came out. So these are the images before and after removal. You can see that the punctate mark here, the perforation mark, but there was no perforation or mediastinitis post removal, no bleeding also. So this was a story of an elderly gentleman where the sister had they had cut aluminum foil with the medicine and kept it by the bedside and had told the patient to take the medicine. Patient, being elderly, had forgotten to remove the foil and swallowed it with the foil. The foil as well as the medicine. And you can see that we were able to remove it, but there was one learning experience while removing this. This was in 2010, I think. We could remove it. Initially, it got stuck at upper esophageal sphincter. So with little maneuverability, we could remove it out. After 4 hours, I got a call that patient is having pain at throat area. Just went, examined him. There was crepitus here. So put in a Ryle's tube, 3 days of antibiotic, nil orally. 4th day, patient got discharged. So this was one case. At retrospective analysis, I thought that OR tube should have been used here or some cap fitted, but yeah. This was a story of a 4-year-old child while playing had swallowed the zip part of it, the pant zip. And this ingestion was 5 days prior to when the patient came. They came with abdominal pain. Just got a X-ray done, and we could see this foreign body. Initially, I tried dislodging it. It came out, but there was a large ulcer here. So kept it in the stomach, and with the help of snare, could remove it. So you can see that the ulcer which is there. Just with the basic medication of 3 to 5 days of PPIs, patient was all right. This came out successfully. Cloth clip, again swallowed accidentally by a child. And whatever accessories we use have to be, whatever we have it at our local place, we have to use it. So this also came out. Foreign body, another thing is some patient had swallowed a cap of this Jandu balm thing, maybe inspired by this song. And coin impaction in esophagus. Usually coins don't get impacted in the esophagus unless there is some prior narrowing. Usually they pass on to the stomach area, but unfortunately for this 5-year-old child, it had got stuck. And this ingestion had happened 1 week prior. For 1 week, they were just roaming around. So this is how you can see, once we visualized what is happening, held it with rat tooth forceps, and then removed. Fortunately, no perforation, nothing. But there is edema which subsided with IV medications. This was after the successful removal of the coin here. So these are some of the images representing the same. Sometimes foreign body could be in the form of vegetative particles like groundnut seed, or sometimes this coconut thing, and tamarind also. The issue is that whenever there is vegetable foreign body, it swells as it is there in the esophagus or stomach. Usually these people are having esophageal stricture. It could be GRD stricture or it could be post-RT strictures. One has to be careful here that when we use these things, the snares and everything, basket and snares, we should not catch hold of it very tightly. Otherwise, there is a risk of cutting through this foreign body. So you can see here that there was some stricture here. That's why the foreign body had got impacted. This is that groundnut which I had mentioned, and coconut thing also. You can see the power of acid. What happens when the coin is there in stomach for a long time. So this patient had swallowed 2 weeks back, and the local pediatrician thought that it will pass off naturally. So second day they did endoscopy and they found that there was a movement of this foreign body lower down. So they thought that it has gone in the small intestine. And after 2 weeks, when patient came back, incidentally they just got an X-ray and it was still there only in the stomach. So you can see that this is what has happened to the coin. We could remove it, but I just have kept these coins for comparative thing. So you can see that the whole thing has got corroded here. Now, there is always a dictum that is advancing points puncture, trailing points don't. So this baby had swallowed the nail. So there was one more learning lesson when I was removing this. So it came out till the oral cavity, and then suddenly it slipped. So now fear was whether it will go in the trachea. So till this point it was coming good. Yeah, here it slipped, you can see that. At this point it got slipped out. So just removed it. Patient was intubated. Patient was not intubated at that time. I had tachycardia because I had to go in again and remove it. I was not sure where the foreign body was. And fortunately, we had this one, Magill's also, but then I again re-intubated and saw that the foreign body was just about to enter the trachea. It was just lying here. Could hold it and get it out. Again went in. This was at the second attempt. So another learning point here and retrospective analysis was whether snare could have been used instead of rat tooth forceps. So as we go on removing this, we become wiser, but at that nth hour, when we are doing the procedure, it is what we are doing, that is the final thing. So all retrospectively, things look good. So this was another boy with safety pin injection, which was in the esophagus, here. So initially I pushed it into stomach slowly. This is a little slow video, I'll just, yeah. So I could catch hold of that, this part of the, this one, pin, safety pin. The open, this was open pin actually. Here we had used the, this one, safety measure. We could catch it and pull it into, little bit into the scope. And this band ligator, this one, the front part, cap of it. So that was very helpful because instead of having this type of V, it became little more acute rather than obtuse, the angle of the pin. So you can see that it is manageable here, but even while coming, one precaution has to be taken is that you go on putting extra air in the esophagus. Put air so that it is distended Yeah, so this is the point where we will be worried whether when we are removing, whether it will start perforating, but put extra air here, remove it slowly, don't have any jerky movements here. And it was successfully removed here. Most dreaded foreign body, what we are worried about is of the batteries and button batteries. This is common ingestion. This was a story of two siblings. They were playing. One sibling, elder sibling, said that I'll put chocolate in your mouth, close eyes. And the elder sibling put, that is 6-year-old, she put this battery in her brother's mouth, and brother swallowed it. So was able to catch hold with the snare and basket and remove it. One thing is that it is foreign body battery ingestion is an emergency one. Usually for other foreign bodies we wait for 4 to 6 hours, but here it has to be as soon as possible here. One thing here is that fortunately, even though it had held in 2 places, I could be able to remove it. See here, this is a final which has come out. And sometimes what happens is that they would, majority of the parents give either banana or something to eat and then remove. In that case, don't wait for 6 hours or 4 hours for the food to go down. Intubate the patient, do it, but do it under fluoro, because sometimes these foreign bodies are not visible when food is attached around it. So take care of the fluoro, take use of fluoro and remove such type of emergency foreign body ingestion. Another case of foreign body ingestion, we insisted we'll proceed with endoscopy. Patients initially, relatives refused. They went outside, came back after 12 hours. This is 3 hours post-ingestion. They came here after 12 hours already. This battery is lower down. And at third day it is here. Patient was absolutely fine till this point. So I want to know from the floor, what would be your approach here? At 72 hours, it has still not passed. I feel it could be ileocecal junction. Anyone would like to proceed with either a colonoscopy, ileoscopy removal, or surgery, or wait and watch policy? Foreign body, battery.
Don't wait and watch. You have
But-
to remove it.
yeah.
You can't wait and watch.
Yeah. So
You
what
have to
would be,
remove it.
I mean, surgery or colonoscopy removal?
Colonoscopy, obviously.
We insisted this person to undergo colonoscopy. They refused. They went DAMA, no trace after that. Most probably it must have gone. I'm not sure. So denture removal, as you know, again, one more thing which we commonly remove. The risk of perforation here is little high. And this is one of the last videos which I want to show. This is that flat pin used for the nut tightening. I think it is used in sieving machine or somewhere. So this, again, one 4 or 5-year-old boy had swallowed it. Could hold it with rat tooth and remove it. And I'm sure majority of our endoscopists here, experienced and seniors, they would have removed much more than what has been shown here. But due to lack of time, I have just shown few foreign bodies. And this is in nutshell. And what foreign bodies have to be removed urgently and which can wait. And where surgical help is required. I have already mentioned that in the previous slide. So friends and seniors, to summarize, most foreign body ingestion, that is 80 to 90% pass off spontaneously. Depending upon where the object is lodged and what is the object will determine the best course of treatment. And as we know, flexible endoscopic treatment is safe and reliable procedure with a high success rate as high as 95%. Thank you. And if there are any questions, please.
Sir, hello sir.
Yes.
Is it better to take a help of anesthetist to intubate every time?
All
Every
patients, initially what we have done, Dr. Kulkarni
Intubate
sir,
the patient,
yeah,
basically,
it
intubate.
is intubate.
So every patient you intubate?
For all pediatric we intubate.
Elders?
Elders plus minus, we depend upon what is the foreign body.
But there should be a rule that it should be better to intubate and prevent.
Point well taken, but anesthetist is always there with us. And if there is any doubt whether the foreign body is there in stomach or gone beyond, in spite of doing X-ray, CT, we go to the OT under CM guidance, sometimes it is removed.
How often you use sucralfate or anything post-op?
Pardon, sir?
Sucralfate or anything, oxytac?
It depending on if there is any ulcer which is formed, we use PPIs and coating agents.
Can I ask a question?
For the esophageal foreign bodies, especially in the elderly, do you take a biopsy after the foreign body has been brought out to look for eosinophilic
Yes, sir.
esophagitis?
Yes, sir. If there is stricture, definitely we, and majority of patients, what we get is either CA esophagus post-RT or post-operative with a stricture. But if there is first time, if the if the foreign body is lodged and they don't have any prior history of endoscopy, we take biopsies just to make sure that we are not missing out on a malignant stricture.
Talk about eosinophilic esophagitis.
Pill-
Very often, eosinophilic esophagitis.
Pill esophagitis.
No, eosinophilic.
Eosinophilic, yes, sir.
So for them, I would take a biopsy every
Yes, sir.
elderly, especially with the history of recurrent
Recurrent,
food bolus
yes.
obstruction.
Yeah.
I would look for eosinophilic
Yeah,
esophagitis.
eosinophilic esophagitis, yes.
Hello, sir.
Yeah.
Many times we hear the news that there are multiple nails in the stomach and all that, all these
Yes, sir.
psychiatric patients. How is it possible?
No, they swallow. Even we will be surprised. I have not shown one example, one case here where a 25-year-old man with depression had swallowed the barber's, this one, blades. I mean, both sides, what we used to use initially for shaving. He had swallowed the cut part of it. I mean, they make it into 2 pieces. He had swallowed 10 pieces. 10 pieces, absolutely asymptomatic, was admitted in ICU. 6th day, no foreign body found after doing CT. Has come out luckily. So, and some of these cases with multiple foreign body injection, they have some psychiatric illness or depression or anything. Some of them would be having trichobezoar type of thing. The hair, what they swallow, or sometimes what we have seen in news, multiple toothbrushes, multiple metal foreign body injection. If there are multiple, then best would be to do surgery and remove at one go, rather than attempt repeated endoscopic attempt. That way.
What is the protocol for injection of batteries?
Battery injection protocol is as soon as possible it has to come out. Because it can discharge and it can perforate the track. I mean, it can discharge. I mean, it can give rise. The case what I showed already was showing some signs of erosions at stomach area. So very dangerous. Another thing is dual magnet injection. The most dangerous thing, because perforations are known in dual magnet injections.
Thank you, sir.
Thank you.
Very nice
Sir,
lecture.
last question.
Yes.
Any case you encountered after the removal of the foreign body, there is perforation or midastanitis or missed out.
One case what I showed you about the aluminum foil, the thing which the patient had swallowed. So definitely I knew that there is a problem when I was removing, because it had got stuck in the cricopharynx area. It came out, but I was sure that there will be some problem. So I'd asked the patient's relatives to ring me up after 4 or 6 hours, and 4th hour I got a call that he's having pain. So called the patient back, admitted, saw for the Krebs test, put in a Riles tube, fed him IV antibiotics. On 5th day we discharged. But so those things like whether OR tube would have helped here or whether the cap assisted would have helped, definitely would have made a difference. But we did it, and these are all, as I mentioned, they're all hindsights and retrospect things which we become wiser.
In our place, we see many times the new endoscopist, they try to push the foreign body stuck into the esophagus into the stomach so that it will pass out on its own.
No, sir.
I think we should avoid those things.
No, not that way. It all depends upon what the foreign body is, and why they push it into the stomach is that catching hold in the stomach becomes easy.
That is okay, that we also do, but sometimes they tend to push the foreign body into the stomach, and during that time we get many patients with esophageal perforations. So I think we should avoid that. Pushing is not every time safe. Most of the time pulling it out is safer.
Thank you, sir.
Thank you.
Due to time constraint, we will stop here. I request moderators to felicitate Dr. Sanjeev Chatni. I request Dr. Shirish Kale sir to felicitate our moderators. He has returned from a new life. Second inning.
There is a small announcement. People who are still not checked out of the hotel rooms, please check out. The timing is over for checkout. People who are not checked out from the hotel rooms, please check out. You can keep the luggage here.
Thank you. Thank you, Dr. Kale sir. Now the next lecture will be on liver transplant. I request Dr. Santosh Hazare from Kelly, Belgaum for this lecture. And chairpersons for this lecture are Dr. Anish Amte, Dr. Vijay Kanse, Dr. Sharad Desai, Dr. Vijay Khullodi, and Dr. Siddharth Dharamsi. I request all the chairpersons to be here. Dr. Anish Amte, is he here? Dr. Vijay Kanse. Dr. Vijay Kanse, sir, yes. Dr. Sharad Desai, please. Dr. Vijay Khullodi, I think he is not here. Okay. Dr. Siddharth Dharamsi. Over to you, sir.
Good morning, everyone. At the outset, I would like to thank the organizing team here and Dr. Dharamsi sir for calling me here. I'll be talking about liver transplant in Belgaum. Actually, I think the last meeting we had, there was a talk about liver transplant in detail. My talk would be not academics, but I'll talk to you about why and how we started liver transplant in Belgaum. As we all know, the incidence of liver disease has been growing worldwide. It is estimated that there are about 2 million liver-related deaths annually, and about 4% of all deaths that occur worldwide are because of liver disease. Globally, it is said that about 1.5 billion people suffer from chronic liver disease, and the prevalence in India is also quite alarming. They said about 180 to 225 million people have chronic liver disease. This is data by Sarin et al. We also have data from state-wise burden of liver disease in India. This is by Dsgecon et al., which shows that surprisingly Karnataka has the highest number of liver disease, the burden of liver disease. Population screening has shown that about 43% of patients have non-alcoholic fatty liver disease. Out of that, 27 to 30% go on to develop chronic liver disease. And there is good incidence, good prevalence in other states as well, like Andhra and Maharashtra. So liver disease is something that all of us are experiencing in our day-to-day practice, and it is there everywhere. As I said, in Karnataka, the highest rates of NAFLD have been recorded. In KLE Hospital, I just went through our data. Out of the in the last 5 years, out of 10,000 patients which are admitted in our hospital, about 30% or more of them have got chronic liver disease. And as you know, many of them we do advise liver transplant. I have this habit of conducting camps here and there in and around Belgaum. And the last about 10-15 years, I've been conducting camps around Belgaum and its periphery. And we have screened a lot of population. And we have found a couple of surprising things. In places like Bagalkot and Jamkhandi and Ramdurgi and Belgaum, the incidence of hepatitis B is quite high compared to the national average. We found data up to 6 to 8% of population being positive compared to our 1 to 2% of national incidence. Similarly, hepatitis C also is quite high in this area. So also, in our department, we have done studies in Belgaum city per se about screening for NAFLD disease with a fibroscan machine. And we found that a lot of our asymptomatic patients who are quite okay and quite normal in the community also carry liver disease, significant of them having significant fatty liver as well as fibrosis. So it goes to say that the liver disease is very much prominent in the community, and a lot of us are going to experience more and more patients coming to us with chronic liver disease and those requiring liver failure. The catchment area for Belgaum, as you all know, it includes North Karnataka, South Maharashtra and Goa, and that's why we have a large incidence of chronic liver disease reporting to our hospital. So with such a large population of liver disease, we should know what is the status of liver transplantation in the world as well as in India. It was reported that about 27,000 liver transplants were done in the world about 4 or 5 years ago, with a 1-year survival of about 84% and a 10-year survival of 61%. In the US, about 10,000 transplants were done, and most of these transplants are predominantly disease donations, which happen there. The figures show that in India, we had about 4,000 transplants, around about 4,000 transplants in the year 2022, and we were ranked third globally behind US and China. Out of that, 81% of the transplants were living donor-related transplants, and we were actually the highest number that any country could do. In the last recorded data is 2023, wherein about 4,500 transplants were done in the country. But these numbers are still not enough. It is estimated that around 40 to 50,000 patients are there in the line who require liver transplant in our country. And another thing to get your notice is that most of our transplants which are done in Delhi and the northern part, a significant number of them are for non-Indians, that is for foreign nationals who come to India for transplantation. So about 1,000 to 1,500 transplants are done for patients who are outside India. So we Indians are actually lacking behind as far as liver transplant is concerned. So we have to have new centers where liver transplant can be done, and that's why this entire effort. Coming to the number of liver transplant centers in India per se, we have about 183 transplant centers registered all over the country. Out of that, there are about only 25 centers who are doing active programs. That is, they're actually regularly doing transplants of more than 20 per year. Another thing about the transplant programs is that majority of our transplants are done in private hospitals and private institutions. Government programs are contributing to less than 2% of the entire transplant program in the country. Geographical distribution also, the Delhi NCR region has the maximum transplants done, more than 1,500 per year. Tamil Nadu, Maharashtra and Karnataka are the other places where transplants are done in a significant number. Another thing is that most of our transplants are done in metropolitan cities and southern states. If you see the transplant data, majority of our transplant centers are in tier 1 cities like Delhi, Gurgaon, Mumbai, Pune, etc. In Karnataka, they are mostly restricted to Bangalore and Mysore. And this uneven distribution emphasizes the strategic importance of establishing a new full-fledged liver transplant program somewhere in a tier 2 city like Belgavi to serve the underserved population of North Karnataka and surrounding regions. And that is why we thought about doing it in Belgaum. As we all know, there are two types of transplantations done. One is the LDLT or the living donor liver transplant, wherein a portion of the liver is donated by a living relative. Predominantly, this is the predominant mode of transplantation in India today. And the DDLT, wherein the disease donor liver transplant, the transplant uses organs from brain-dead donors. These are less common, but the incidence is gradually increasing. In North India, where the most of the transplants are done, the most common type of transplant is the LDLT, wherein more than 97% of the transplants are done in the LDLT form. In South India, there is a mixed ratio, wherein about 30% of the transplants are done in the DDLT form. Coming to the need for OLT at Belgaum, there is no dedicated center for liver transplant in the entire North Karnataka, the entire state of Goa, and also South Maharashtra. For us in Belgaum, all our active liver transplant centers are more than 500 kilometers away, that is Bangalore and Mysore, and Pune about 350 kilometers away. That's why we were realizing that all our patients from Belgaum and North Karnataka We used to travel 8 to 12 hours to go to a transplant center. There used to be a delay in evaluation and listing of these patients, the increasing decompensation and mortality before surgery, and they used to find difficulty for follow-ups for these patients post-transplant, which they required for the first 3 to 6 months. Many of our patients were feeling anxious and uncomfortable about going to large and unfamiliar cities. The transplant cost also is very high. An additional stay of about 3 months in the metro city for pre- and post-transplant care increases the expense. Extra costs include accommodation, travel, food, and daily living expenses. For patients who are from smaller cities, these demands were too much. Some patients would delay or refuse transplant programs. Many of them used to die without getting a transplant done. So we thought about a transplant program in Belgaum, and we thought that establishing a program in Belgaum will reduce the patient reference to metro cities, lower the treatment costs, improve survival rates, enhance regional healthcare infrastructure. And given the high prevalence of liver disease in Karnataka, this initiative will serve us as a critical hub for liver care in North Karnataka and neighboring states. Another aspect about our program in KLE Hospital is that the treatment cost is much low, and it helps economically disadvantaged patients, because we at KLE, in the KLE program, allow our patients to utilize government schemes like Ayushman Bharat, ECHS, ESI schemes, and Arogya Bhaka schemes for police personnel, which subsidizes the total cost of transplant. These schemes contribute to more than half of the transplant cost for the patients, and that is why it's very easy for them to get transplants done at our center. We at KLE thought that we would have to have a long-term transplant program which would stand alone in some time, unlike few centers who had done a one-off transplant here and there and the program fizzled out. So the setting up of a transplant unit has many requirements, like hospital infrastructure, dedicated ICUs, high-tech OT equipment, modular OTs, and most importantly requires highly trained surgeons, hepatologists, anesthetists, trained nursing staff, support staff in the form of coordinators and counselors. It is difficult to have all of this from day one, and for that reason we thought we should collaborate with somebody, and that's why we had a collaboration with Astro Hospitals Bangalore, who had an experience of doing more than 700 transplants, and we had a KLE Astro Hospital partnership designed to establish a program in Belgaum with a long-term association was put in place with the goal to make our program at KLE self-sustainable with time. In the two types of programs, we thought that we'll go ahead with the DDLT program first, because the low risk and complexities associated with the program. And to start this DDLT program, we took some initial steps for starting the program. A specialized clinic was started with fixed days and OPD days and timings to cater to chronic liver disease patients. We set up a 8-bedded liver ICU. Then we had 2 modular high-tech OTs for the transplant. We set up a high-end 4-bed post-transplant ICU for keeping the patients after transplant separately made for these patients. We set up a CRRT unit which was not there initially for our AKI patients. Many of our patients post-transplant would require renal replacement therapy. We already had a very high, we already had an IR department in our college, so that was helpful for us. And to start with, we began our surgery with major liver resections before going on to doing the transplant directly. There are certain requirements for a DDLT transplant program. There is to be something called as the brain death declaration has to be done for patients, and we have to follow the Transplantation of Human Organs and Tissue Act. We have to have a registered hospital certified by Brain Death Declaration Committee. The Brain Death Declaration Committee has got 4 members. Actually, we have to pick them up. The doctor who is in charge of the patient, a neurologist, a neurosurgeon, or intensivist, and the in charge RMP of the hospital. At least 2 of these doctors must be from outside the treating team. We have to have the hospital has to be liver transplant registered from the state. We have to actually train our ICU staff to pick up, identify, evaluate, and document brain dead patients according to THODA guidelines. We have to have transplant coordination unit wherein we appoint dedicated coordinators, nursing counselors, and grief counselors to identify patients who are brain dead, who have to go to the family of the brain dead patients, motivate them to donate organs. This all looks very easy, but very difficult in day-to-day practice. As we were talking yesterday, we have to have the support of our neurosurgeons and neurologists who can come forward and give us their patients. Once we identify patients in the ICU, very difficult for us to go and ask the patient for organs. So as doctors, we can't do that ourselves. So we have to have coordinators who are trained in this. They are grief counselors, they are nursing coordinators who come and talk to the families. There are multiple sessions required to talk to the patient's relatives and convince them. And it took us some time to do all this, and we have been doing this last few years, and somehow we have been able to manage. Now we have got a very good coordinators team who come up and live up to our this thing. Then we have to have all of them are to be NOTO certified. This is a national organization which gives them certificates for counseling and documentation. We had to actually make our society very aware for EDLT, for organ donation. So there's a foundation called Mohan Foundation. We had to call them, and along with them we had a lot of awareness programs in the community. And we continue to do that even today, that we have to promote organ donations. People don't know what is DDLT and what organs are donated and how they are donated. So even actually, to tell you frankly, the doctors themselves don't know when the organs are given and when they are taken. So all this has to be taught to the community. We had to do a lot of organ awareness campaigns, and somehow we have been able to do this, and we are getting donations nowadays. So all this was done. In addition to that, we had to do a capacity building for the staff itself. We had to identify core team members, including ICU staff, OT nursing staff, in-house GI surgeon, hepatologist, and everyone. We actually sent our staff for training at Astro Hospital, Bangalore in turns. We sent the liver ICU staff for about 2 to 3 months of training. Our OT nursing staff for training there to the same hospital. The in-house GI surgeon and I myself had gone to get some extra training done for post-transplant management of these patients. And finally, we started listing patients for DDLT from our center. Most of the patients are from North Karnataka, South Maharashtra, and Goa. We performed our first liver transplant in a patient with known Wilson disease. The patient recovered well and was discharged about 8 to 10 days after surgery. We was very fine. The success of this first case gave our team the confidence and motivation to move forward and continue this program. We all know the indications for cirrhosis, for transplantation, patients of cirrhosis who have got a MEL score of more than 17 or a Child-Pugh score of B or more than 9, we list them for, we start thinking about transplant in these patients. Or patients of cirrhosis who have got complications like ascites, bacterial peritonitis, hepatorenal syndrome, recurrent encephalopathy, variceal bleed which is not controlled, or people who have got poor quality of life, recurrent cholangitis, HPS, or portopulmonary hypertension. Decompensated cirrhosis with complications, poor quality of life, hepatocellular carcinoma with Milan or UCSF criteria, refractory ascites, hepatorenal syndrome, hyponatremia, or selected pediatric conditions also like biliary atresia and metabolic disease. These are the conditions wherein we refer a patient for a transplant. This is the Milan and UCSF. I will not go into details of this. There are certain contraindications for transplant like untreated HIV patients, active alcohol and drug abuse, advanced heart and lung disease, extrahepatic cancer or liver cancer with vascular invasion, uncontrolled infections, multi-organ failure, severe pulmonary hypertension, or patients who don't have a family support or who, we have realized that before and after transplant, the patient requires a lot of family support and counseling and a lot of care. So patients who have got all these things, only we can motivate them for transplantation. In 2024, there are very few absolute contraindications to liver transplant. The post-transplant survival is quite excellent, with 1 year survival rate of more than 80 to 90% and a 5-year survival of 70% or more. That is why patients who have got a Child-Pugh score of more than 9 or a MELD of more than 17 should be motivated for a transplant. Nowadays, even ACLA patients with type 1 and stage 1 and stage 2 benefit from early transplant, and also a select group of patients with HCC are also benefiting from liver transplant. So these are the patients whom we have listed and done transplant at our center in the last 2 years. We have the highest MELD was around 32 whom we transplanted, and we have the entire spectrum of liver disease actually. So far we have done about 21 liver transplants in 2 years. There were about 2 Wilson's patients, 6 patients with metabolic associated steatotic liver disease, 1 Budd cherry, 9 ALD patients, and 3 cryptogenic cirrhosis. During these transplants, we encountered many difficulties, some technical, some in relation to personal instrumentation, and few complications that require prompt recognition and intervention. We actually experienced 2 mortalities in the 21 patients. One of our patients succumbed to brain hemorrhage post-transplant due to accelerated hypertension 8 weeks post-transplant. Some of our immunosuppression drugs which we use after transplant, we have to monitor the blood pressure. And even though we were monitoring this patient's blood pressure, he suddenly had a high blood pressure on one day in the house and he had brain hemorrhage. And we lost him. The second patient we lost to multiple biliary strictures because of ischemia. And these strictures went on to develop sepsis, cholangitis, and then we had to lose him after 3-4 months after transplant. There are other complications post-transplant of the hepatic artery thrombosis. 2 patients developed hepatic artery thrombosis, a serious vascular complication. Both cases were successfully managed by our in-house intervention radiology team by balloon angioplasty and stenting, restoring adequate hepatic arterial flow. One of our patients post-operative had a hepatic artery stenosis, and this required a re-exploration and anastomosis with a graft by the surgeon. One patient developed a remote, after 4 months of transplant, developed a CVD stricture, and we did an ERCP and CVD stenting, and he recovered. After 21 successful DDLT transplant, we took the next step in our liver transplant journey. On 20th June 2025, we have performed our first living donor transplant in North Karnataka. Here, a son donated a part of his liver to his father, who was battling from MASLD. Both the donor and the patient recovered uneventfully and have been discharged 1 month ago. So to conclude, now we have about more than 30 registered patients waiting for DDLT at our center. We are also working for a few patients for living donor transplantation. And we are one of the few medical college hospitals in the country to set up an OLT program like this, and possibly the only one in the private setup. And I'm very happy to tell you that, and I wish that you can make use of our transplant center and refer your patients who are willing to come to us. Thank you.
Congratulations, Dr. Santosh.
Thank you.
We have also at Krishna kidney transplant program, and we have also done successfully 33 kidney transplant, not a single failure. I must appreciate, and on behalf of DAG, we appreciate your efforts, mental and physical efforts you have taken to establish all this at Belgaum Center. Really creditable, and congratulations once again.
Yes, sir. Thank you.
How much is the cost, sir, at your institute?
Madam, it varies from 22 lakhs to 25 lakhs. For our patients in Karnataka, madam, we are using the schemes there. Okay. So most of our Karnataka patients use a scheme wherein more than 50% of the money is being reimbursed by the government.
What may be the etiological reason that you said in Karnataka more patients with non-cirrhotic liver disease?
Now there are 2 things, madam. One is these fatty liver disease in Belgaum and around Belgaum, madam. Like in any other metro city now, the incidence of fatty liver is going up. And that's why possibly the lifestyle and the obesity and diabetic epidemics in metro cities or in cities like Belgaum are adding to the liver disease burden. But there are pockets in and around Belgaum, like I said, areas like Bagalkot and Ramdurga, where I have done a lot of these camps, sir, madam. There somehow we have found the incidence of hepatitis B and C is quite high compared to the national population.
Is it because
possibly there are some communities which are inbreeding. There are some different communities which we have come across who have got inbreeding among themselves, and there the incidence of these B and C viruses is quite high, and they land up with chronic liver disease.
Okay, is it because of the malpractice in the general practitioner hepatitis B is more?
Maybe it's very difficult to document that, madam, but this is very much confined to communities. So maybe it is more of inbreeding, living within themselves and marrying among themselves, causing that, madam.
Okay. It's many of the radiologists nowadays, when they report, they most of the time for the liver, they put it as a fatty liver, and patients start asking us.
Yeah.
So when we should aware them, a NASH can be with them?
Yeah, madam, actually, majority of our patients who have got fatty liver, most of them are benign fatty livers, as we see them in the community. But every patient with fatty liver has to undergo 2 tests at least to know what is happening to the liver. One is the liver function test to see for the enzymes SGOT, AGPT, and gamma GT. And the second is to do a fibroscan test. Okay. The fibroscan is a very reliable, very important, very simple test which we do now. In fact, we are taking the fibroscan to the community and doing this test instead of doing the ultrasound. And the fibroscan gives us 2 readings, madam. It shows us the liver fat and it shows what is called as the fibrosis. So the liver fat is the one which is important, which shows we have got these gradings of fat in deposition, madam, S1, S2, S3. Depending upon that, we can know how much is the fat there. If the fat is above 275, we usually would think about treating the patient. Most of the patients will be having a fat less than 250. We leave them alone. So above 250 or 275, we start treating them. Initial treatment would be only diet and exercise. But patients who have got liver fat for a long time in their liver would start developing fibrosis. And then the fibrosis, the LSM score of the liver starts increasing. Normally it would be less than 7. From 7 to 8, we say that it's just the beginning of fibrosis, but above 8, we start treating the fibrosis. So once somebody has gone above 8, we would, in addition to diet and exercise, also recommend them drug therapy.
Okay, thank you, sir. Yeah. Thank you. Any questions from the floor?
Sir, excellent presentation.
Excellent talk. Congratulations for your this endeavor. Definitely, this will help from patient from our side also, because this area drains North Karnataka, which is draining.
Somehow I don't know. The Maharashtra government has no scheme for liver transplant. I think I have to
maybe
ask.
by the
Santosh, it's the Kannada patient that we see.
No, I know, sir.
So
that
we send them back to you.
Yes, sir.
And they'll get all the relief of.
That is thanks to you, sir. But I am asking you for Maharashtra patients also, sir.
No, because there's no scheme for
There is
Maharashtra
no
patients.
because a lot of our patients come from Maharashtra, but they don't have a scheme. Yeah. That scheme which is running now doesn't include liver transplant actually.
That can be managed, sir.
Mahatma Phule thing, I think. Yeah.
They can go to Karnataka and change their Aadhaar card. Something can be managed.
Santosh,
Okay,
my
thank you.
question is pertaining to the HIV positive patient. It was a contraindication, now it has become relative contraindication. So you said it is a pre-treated patient. So what are the criteria where you list this patient for HIV positive patient?
No, HIV positive patients, we have to see their viral load and their this thing. Only then if the viral load is low, they are on long-term treatment, they have been inactive for a long time, we can think. But in our center, we are not doing such patients.
And any modifications for immunosuppression post-transplant?
Yeah, there are modifications. we have not done any HIV patients still so far at least, so we have not done any patients.
Santosh, we are very proud of you.
Yes, sir.
You are one DSG guy who's doing fantastic work. So congrats and keep it up.
Yeah, thank you, sir.
Thank you, sir. We'll stop here. I request moderators to felicitate Dr. Santosh Hazare. I request Dr. Chinmay Gandhi to felicitate our moderators. Now we have a next talk lecture on interesting cases by Dr. Sanjay Altekar from Goa. Chairpersons for this session are Dr. Chinmay Gandhi, Dr. Pramod Ingre, Dr. Ravindra Yadav, Dr. Abhiman Rao Pawar. Over to you, sir.
Thank you. Good afternoon, everyone. I'm happy that there are still lot of audience, despite it being late in the afternoon today. At the onset, let me thank the DSG Society, including the Sangli Surgical Society, Sangli Blood Club, as well as the IMEs. I'll be presenting two cases. One will be a common case, but maybe my surgical co-colleagues must be missing it at times. And the second will be a rarer case. We'll start with the common case first. Slide. Okay. Some things have been missed over here. This is a 50-year-old lady who has been recently diagnosed with Graves' disease and started on therapy. This lady presented with mild weakness and itching, and also noticing jaundice for the last 1 week. There was no history of any prodrome, no weight loss, no history of any joint pains, rash, or watering of the eyes or redness of the eyes. She did not have any comorbidities except for Graves' disease, which was started on therapy about 6 months back. There was no other comorbidities. Sorry, I think. On examination, there was icterus, there were no scratch marks, and there were no other signs of liver cell failure. Definitely she had signs of thyrotoxicosis still present, like tachycardia, exophthalmos, and tremors. Per abdomen examination was not contributive. There was no liver, no spleen, no ascites. These were her labs. If you see the labs, it's showing conjugated bilirubin with enzymes varying from 2 times to almost 10 times
the normal, and alkaline phosphate is right from 5 times to 10 times the normal limit. This is the full chart. Initially, she was managed by a physician for the first 2 months. Subsequently, a surgeon saw in the month of September and October, and I saw her in December, somewhere at the end of October. So this slide will show you that she had a mixed picture, both in hepatitis as well as a cholestatic pattern. So at this juncture, anybody wants to comment on anything? What would be the diagnosis, or you want more tests? Anyone from the audience can comment. Surgeons, my medical gastroenterologist, I think they'll think of the diagnosis. Slides aapne pade. Other blood tests including PTINR, viral markers, all viral markers were done. Hepatitis A, B, C as well as E were negative. Ultrasound was normal. The biliary radicals were normal. CBD was normal. No gallstones. The lipid profile showed triglycerides which were 2 times normal. What would be the next test you would want? Anyone is comment? Amol? Tell me. Yeah. MRCP was done. MRCP was normal. Actually, this patient came to me with a full battery of tests. I saw her almost at the end of 3-4 months. All the autoimmune panels were negative. Anti-mitochondrial antibodies were negative. She had a CT scan with contrast which was negative.
Any drug history, sir, on the panels?
The only thing, she is a case of Graves' disease, no complementary and alternative medicines, no. Retic counts are not done, but hemoglobin was around 14 plus, so it was normal. And here it is a mixed picture, both cholestasis as well as hepatitis. CT scan was normal, MRCP normal, tumor markers were normal.
Platelet count?
Platelet count was also normal. Eosinophilia 3%.
Okay. So
normal. So what next? So? Gastroscopy was not done, sir, in this patient, not. Any indication, anything particular you're looking at? Because, pardon, sir? Yeah, CT scan was normal, so CT scan was no nodular liver.
In view of fibroscan score 14 sir, on the stage.
But, sorry?
On your left, sir.
Who's speaking?
Sir, here.
Yeah. Tell me, yeah.
In view of high bilirubin, the fibroscan could be falsely high because of high bilirubin and OTPT being more than 5 times. So
correct.
Fibroscan
so this fibroscan was already advised by a physician.
So this could be
falsely high. A good point. A good point, yes.
So liver biopsy would be the next step, ideally.
Directly you would jump to liver biopsy.
As we have ruled.
I know this is a falsely high fibroscan score because enzymes are high, alkaline phosphate is high. So I would not. So definitely no endoscopy. No complementary Ayurvedic medication. I thought my medical gastroenterologist will get up. Yeah.
Ophthalmological exam for Wilson's.
Tell me. Yeah, good. Amal has got it. I thought. So what was the diagnosis? So instead of jumping to a liver biopsy, I think yes. Always we have to keep drugs in mind. For many of the diseases, drugs. I think day in and out we see, but most of us would miss. In fact, literature also says that we would not put it on the document. We would not write it on the. Though we know it is drug-induced liver injury, we would not document our discharge cards. Most of us would not write it. So this is this patient was a propylthiouracil. That was the cause of drug-induced liver injury.
So just one comment, sir.
Yes.
Especially in such cases where people are on drugs, there's a website called livertalks.com.
Yes.
And we make it a point that any drug that you are not sure, put it on that list and you will get a kind of parameters what these things happen, what
Definitely.
are the enzyme elevations after such drugs.
Yes.
And most of the times you find out that.
Yes.
Because many things we may not remember from our past days.
I agree to that. Yes, definitely yes. So on the one side, almost half the patients with thyroid diseases will have mildly raised enzymes even before starting. Maybe 1 to 2 times normal they will have. But rest of the biochemical parameters will normal. So like any other drugs, propylthiouracil also can cause liver toxicity, majority of them may be asymptomatic to a full-blown liver failure as well as death has been reported. Usually it is an idiosyncratic drug reaction and may start anywhere from 2 to 12 weeks. This patient presented around 6 months later. 6 months later. So what, for the definition of the drug-induced liver injury, any new drug with a rise in bilirubin more than 2 mg/% or liver enzymes high for more than 3 times normal, AST, ALT, or alkaline phosphatase more than 2 times normal, or if no symptoms, AST, ALT more than 5 times normal. Obviously, you have to exclude other causes of liver diseases. This is just for literature. About 2 years back, this study was published, review of literature of all the possible literature available till then. Almost 100 articles were available. If you see antithyroid drugs, they can cause a mixed pattern. Cholestatic pattern around 40% and hepatocellular pattern almost 40%. Coincidentally, this patient, actually if I go back to my slides, she was initially managed by a physician. Somewhere at the end of August, the physician had withdrawn the drug, I don't know for what reason, lowered the dose. Then she went to a surgeon in September. The surgeon again stepped up the dose. So it was almost like a re-challenge. So here I could document a re-challenge which was there. So I didn't do a biopsy of this patient. So a little brief about our Indian network. I was fortunate to, my GI career started from St. John's with Dr. Harshad Devarbavi. Me being a pediatrician, I switched over to gastro. So initial 9 months I spent over there. So in India, the commonest would be anti-tubercular drugs first. Second, complementary and alternative medicine. Third, anti-epileptic drugs. These constitute almost 70%. And if you include anti-metabolites, it will come to cover to around in the 85% of the cases. So only message here be aware of drug-induced liver injury. The elderly are more prone for drug-induced liver injury because of various reasons, because they are already on polypharmacy, many drugs. Also, it is one of the common causes of drug-induced liver failure in our country. Awareness, most important, awareness is required. Associated systemic features, if they are there, like fever, rash, mucositis, eosinophilia, someone asks, lymphadenopathy and renal failure will help in the diagnosis. Always consider drug-induced liver injury in cases of unexplained liver, raised liver enzymes, especially if they are mixed or atypical patterns. Obviously, we have to exclude all other causes of liver disease. Case 2, a young male, he had presented with fever, no fever, loose motions, pain abdomen and vomiting for the last 1 or 2 days. On examination only some dehydration was there, he was hospitalized for that. The rest was unremarkable. This was standard gastroenteritis, like a food poisoning. Coincidentally, this fellow was admitted exactly a year back with similar complaints managed by a physician again, hospitalized for 3 days, hydrated, antibiotics, discharge diagnosis, acute gastroenteritis with dehydration. No history of any allergy or other illnesses. On retrospect, he was admitted with me after a year later. Similar complaints, exactly similar complaints. Previous discharge card on review, eosinophils were around 18%. And for some reason, ultrasound was done, so which showed mild hepatosplenomegaly and minimal free fluid. I think most of you would have got the diagnosis. This time also, again, the eosinophils are around 18 to 20%. Rest all the blood labs were normal. Ultrasound again showed mild hepatosplenomegaly and mild ascites. Stool was normal for parasites. Diagnosis, I think, is quite obvious to my medical colleagues. Yes, eosinophilic acid. So here I also thought of a similar thing because this is the second time. He came to me second time. I was seeing for the first time previously also. So directly I did an ascitic fluid. So treat like an eosinophilic gastroenteritis. Rest of the tests were done in retrospect. First I did the ascitic fluid. These are the other tests to document if there is any other cause for eosinophilia. Stool cultures were negative, endoscopies, colonoscopies were negative. CT scan was normal. IG levels were normal. Also took a hematology opinion. We asked for a hematology opinion. He asked for a bone marrow, which the patient refused to do. This was ascitic fluid which was loaded with eosinophils. ADA was negative in this case. He received a short course of steroids and he improved over the next 2 to 3 months. There was no more relapses in the last 2 years, 18 months. So as we all know, eosinophilic gastroenteritis is a rare disease, of which subset eosinophilic ascites is further more rare, maybe around 10% of cases of eosinophilic gastroenteritis. It involves anywhere right from the esophagus to the rectum. 3 types, the mucosal layers, the muscular layer or the serosal layer. Based on the involvement, the presentation may vary. For the mucosal layer, it may just come like a food poisoning, like this patient, with nausea, vomiting, diarrhea, pain abdomen. For the muscular layer involvement, it may come as recurrent colics, history of suggestive of subacute intestinal obstruction may be there. And for a serosal involvement, ascites will be there. It may not be a disproportionate ascites. Peripheral eosinophilia may be a clue to the diagnosis, but it is not essential for the diagnosis. Stomach involvement around 25 to 80% and small bowel involvement in 30 to 100%. Eosinophilic ascites compared to other causes of eosinophilic gastroenteritis associated with higher peripheral eosinophilia and a good response to steroids. These are other drugs which may be used, especially in steroid failures or who relapse frequently. There was a good review which covered almost 60 years of the last 60 years of all eosinophilic ascites, in which the common causes were eosinophilic gastroenteritis, almost 75%, parasitic infections, and hypereosinophilic syndromes. So before labeling as eosinophilic gastroenteritis in any patient, presence of GI symptoms, eosinophilic infiltration, if there is a mucosal biopsy, more than 15 or 20 eosinophils per hyper filled, exclusion of eosinophilia in other causes, other organs, and no other obvious causes of eosinophilia. I'll skip the slide. You want to? It's a busy slide, so we'll just skip this. From Maharashtra itself, from Aurangabad, Ramesh Satarkar has reported 3 cases about a few years back. Summing up, eosinophilic gastroenteritis is increasingly diagnosed now. More of food allergies we would see. I think all of us would be seeing more and more of that. Eosinophilic ascites is further rare. Symptoms are non-specific, so obviously, unless you have peripheral eosinophilia, you would not be thinking of an eosinophilic gastroenteritis or eosinophilic ascites. Hypereosinophilic syndrome would require a bone marrow for diagnosis. And steroid therapy results in resolution in most cases. Thank you.
Thank you, Sanjay. Yeah, I will ask my pathologist Sagar. Sagar is there, he's very keenly listening since yesterday. In last 6 months, actually, we have picked up 2 patients of eosinophilic ascites. So, you will just highlight how you have picked up and what are the findings, ascitic fluid.
Yeah, you can tell, please.
Actually, whenever we are doing this routine ascitic fluid examinations, whenever we are putting just a drop of methylene blue, actually we cannot identify the eosinophils in that. Actually, we have to make hematoxin and eosinophil slides. And in those HE slides, we can pick up the eosinophils better. Even no senior pathologist can identify the eosinophils on routine examination. So I think one should advise this cytology also. And in cytology, we can pick up the eosinophils better.
Yeah, I agree to that. So seeing this case, I spoke to my pathologist. He was very excited. The moment he saw that, he immediately called up, because I told him you have to look for eosinophils, as Uday directly pointed out. We already had this patient admitted with the physician in the past, and here it was quite obvious. So I told him to just look for eosinophils. The moment he saw that, and he was very excited, like he has never seen in his life. So.
First patient, what we pick up, he presented with actually acute abdomen.
Okay.
And short history of ascites.
Okay. Yes.
Almost more than 25% eosinophils were there. And obviously we couldn't find anything. We did CT also. But except ascites, there was nothing. This thickening of the serosa and everything, it was classical.
Yes.
So I specifically discussed this case with Sagar and asked him to see on that. But this is very important to have good communication with the pathologist.
Yes, definitely yes. Yes.
Sanjay,
Yes. Yes, sir.
they respond to steroids.
Yes.
The symptoms disappear, the pathology disappears. I have 3 patients who have come back with eosinophilic enteritis. So it's something that you should remember that these people can come back.
It can come back, definitely.
Including a doctor who's come back thrice.
It can come back, sir. Yes,
He's
sir.
come back thrice with eosinophilic enteritis. And you can't find a cause. You just can't find a cause.
Actually, there was more literature on that. I didn't write that. The platelet factors, they have to, platelet-derived growth factor, they can look for the genomic marker there. And I didn't put up that for want of time.
In your case, actually, IgE level actually shows normal.
Normal. IgE
normal.
level
But
normal.
in my cases, the IgE level was elevated. And I think IgE level itself is a very good marker to tailor the therapy, to know the end point of eosinophils. What was his query, means what are the, why this patient has recurred. So we have to stop the steroid at the level where we see the
IgE
significant
comes to
drop,
normal.
IgE level come to normal.
To normal, yeah, agreed.
How did you manage that first case with Graves' disease?
Stoppage. I stopped that drug. The drug induced liver.
What about Graves' disease?
The surgeon has taken over.
Do you use hetrazan? Previously we were using for eosinophilia, like hetrazan. Do you use nowadays?
No, we never use hetrazan for eosinophilic enteritis.
Systemic, this is a systemic.
That is mainly for Loeffler syndrome. We have a lot of respiratory symptoms.
Okay.
They respond to hetrazan, not the.
Not these patients.
They are the worm-induced eosinophilia.
Parasitic infections. Okay, thank you. Thank you, Dr. Sanjay Altekar.
I would recommend everyone to visit Amba. Because of Amba, I went here last weekend.
Now it's beautiful.
Marleshwar. Worth visiting. Definitely worth visiting.
Okay.
Hundreds
Thank
of
you.
waterfalls.
Yeah.
Thank you.
I request moderators to felicitate Dr. Sanjay Altekar. I request Dr. Ambardekar to felicitate our moderators. Dr. Chinmay Gandhi, Dr. Pramod Ingle, Dr. Ravindra Yadav, Dr. Abhiman Rao Pawar. Thank you. Thank you, Dr. Ambardekar. Now we are coming to the end of this August gathering with the panel discussion, walled-up pancreatic necrosis. I call upon Dr. Sudhanva Pathak for moderating this session on panel discussion of walled-up pancreatic necrosis. And panelists for this session are Dr. Aditya Kulkarni, Dr. Abhishek Sadalge, Dr. Sagar Kurulkar, Dr. Harshal Bhoi, and Dr. Vaibhav Patil. Panelists will be Dr. Aditya Kulkarni, Dr. Abhishek Sadalge, Dr. Sagar Kurunkar, Dr. Harshal Bhoi, Dr. Vaibhav Patil.
A warm good afternoon to everybody. I know this is the last session. Ideally, we used to do it for 45 minutes, but I'll keep it short. And if my panelists, all of you, if you permit, we can ask a few questions to audience also. Is it okay? Okay. We'll start off. So outline of this discussion would be some introduction, terminologies, and Panther trial, that's a landmark trial that changed the way we treat these wounds. Then management modalities, a few cases on each, case-based discussion, and let's discuss some controversies, and then question and answers from the audience. Pancreatitis is a common entity. All of us, we deal in practice. Walled-off pancreatic necrosis is important because it is associated with morbidity high than other variants. So, first question to my panel is, CT scan is go-to investigation in most cases of acute pancreatitis. So, my dear medical gastro colleagues, when you want to do it? a CT scan in acute pancreatitis?
If you go by evidence, then it is to be done after 48 hours or 72 hours. But there is one entity called as a group pancreatitis.
Yes.
And in that case, it should be done as early as possible when you encounter with the pancreatic pain.
Okay.
So as a medical gastroenterologist, the only entity where the early CT scan, apart from evidence, can be done is a group pancreatitis, because it comes with the normal amylase and lipase level, because it is a focal pancreatitis, and it can be diagnosed only on CT scan.
Okay. Fair enough. As surgeons, when my surgeon colleagues?
Severe necrotizing pancreatitis after, as Dr. Abhishek rightly told, after day 3, day 4, all severe necrotizing pancreatitis, I get the CT scan.
Okay. Yeah. So passing this question to Dr. Patil, radiologist. So please enlighten us how to go about CT scan of pancreas, especially with reference to wall of necrosis.
So sir, as sir said, that we'll have to do the scan usually 3 to 5 days after the onset of pancreatitis.
That is the first scan, but usually wall of necrosis is usually later on in the...
Later on, sir. So because 3 to 5 days later the pancreatic necrosis sets in, sir.
Okay.
So acute necrotizing pancreatitis can be diagnosed on CT only after 3 to 5 days, sir.
Okay.
So when we see necrosis in the pancreatic tissue, we label it as acute necrotizing pancreatitis. So if there is necrosis in the peripancreatic tissue and not in the pancreas, we don't label it as acute necrotizing pancreatitis. It's just a fluid collection around the pancreas. So there are terminologies given by revised Atlanta classification, sir. So there is acute pancreatic fluid collection which turns into pseudocyst 4 weeks later, and there is acute necrotizing collection which turns into a walled off necrosis 4 weeks later.
Okay.
So when it is encapsulated, we call it as a pseudocyst or walled off necrosis, depending on whether there is necrosis in the pancreas or no. So what do we see in case of walled off necrosis is the size of the collections, the location of the collections. Are they causing any mass effect on the adjacent organs? Are there any associated complications like compression on the biliary CBD, which will cause biliary compression symptoms? If there is any pseudoaneurysm in the wall of necrosis, because draining a walled off necrosis with a pseudoaneurysm can be catastrophic. So first we'll have to embolize the pseudoaneurysm and then take up for drainage of the walled off necrosis.
So usually what happens is that initial CT scan is done. Now,
yes, sir. Less than there is classifications. There is CT severity index score which is given in the report, sir. So CT severity index, there is a point system, sir. So depending on that, the morbidity and mortality of the patient is
Can I ask a question?
Yes.
Vaibhav, would you want to do a CT or an MRI?
I would prefer a CT, sir, because CT gives most of the this thing, like it gives almost everything. Only thing is in patients who are allergic to contrast media or who have a severe renal dysfunction, in those cases MRI is indicated, sir. But MRI, if you see, it is better to see the debris or the necrotic tissue. MRI is better, sir. But CT also gives almost every information, sir.
well explained. I want a follow-up question to add. Most of us nowadays routinely do, before going on for a definitive management of one, angiography. As you rightly said, pseudoaneurysm has to be ruled out. But is doing cologram routine, because most of the cases we have already done endoscopy. So indentation of stomach is quite evident in on upper GI endoscopy. We routinely don't do a colonoscopy in acute pancreatitis. So do you add cologram in every case? What do surgeons say about this?
Usually I don't get it. But unless if patient is toxic, suspecting there is some colonic fistula with the collection, then definitely cologram is required.
What is your opinion, Dr. Boy?
Same, sir.
Okay.
Routinely we are not going to do cologram.
It depends upon the how patient is respond to the treatment. If patient is not respond to the treatment, there is continuously abdomen distension. Patient land up in the organ disorder. Patient is not passing stool properly.
Okay.
And in that kind of condition, we are doing.
Okay, only in a selective cases.
Yes.
My personal preference is when I see usually gas in one, at that time I do usually add CT cologram. Dr. Sadalge and Dr. Aditya, anything to add in this question?
Yes, as you rightly said, if there is a gas in the WPN, we usually try to find out if there is a fistula which is there either in the duodenum stomach or whether in the colon. So in that case, yes, we can do, but otherwise as a routine, it is not indicated.
Okay, fair enough. So to the audience, what is this? Is this pseudocyst or a CT? Because Kansai sir had raised this question. How to differentiate a pseudocyst from walled of necrosis? This is walled of necrosis. And is this a pseudocyst or walled of necrosis? Sometimes walled of necrosis looks like pseudocyst, so adding clinical background is also important, I think. So this is walled of necrosis. Sometimes what happens nowadays, it's been like more than 10 years that the walled of necrosis and Atlanta classification has been around. But not all reports are abiding with Atlanta classification. Sometimes we see reports with phlegmon, pancreatic abscess, but usually I think we should all, this already Vaibhav has told, optimal CT protocol, this is according to IAP guidelines. And we should or must stick to standard terminologies while reporting and discussing pancreatic collections. So this is revised Atlanta 2013, that's current. This is what we should use. Dr. Vaibhav, would you want to add something on this juncture?
No, sir, this is the revised Atlanta classification, sir. So in addition to this, we'll have to give the CT severity index, sir, while reporting the cases for pancreatitis,
Okay.
to know to prognosticate better, sir. And in cases where disconnected duct syndrome is suspected, I
Okay.
think MRCP should be added, sir.
Okay. So in the first question, to summarize it, the CT is workhorse investigation for acute pancreatitis, especially when there are collections. So protocols and standard terminologies we have discussed. Now let's come to management. What happens, last 10 necrosectomies that I have done, that has some tube in it. Most of the times a placed PCD in situ. So this is what typical specimen of necrosectomy looks like. So my surgeon colleagues, how frequent is primary necrosectomy, upfront necrosectomy?
Front necrosectomies we are getting nowadays after the Panther trial, which is step-up approach.
Yes.
Upfront surgeries have drastically reduced actually.
Okay.
And I strictly follow step-up approach. Actually, it is a good approach because there is a definitely, if we go in a step-up, let the patient earn his own surgery.
Okay.
That's what I feel. Unless patient is in sepsis or really required, means large collection, large necrotic tissue, I rarely do upfront surgical necrosectomy.
So, Dr. Bhoi, 4 weeks is definition for one. So, as surgeons, we should press for that, wait for 4 weeks. Or are there indications to go in within first 4 weeks in necrotizing pancreatitis?
Yeah, we are waiting for the 4 weeks. But if there is ongoing systemic inflammatory response is more, patient is not coping up, patient is land up in the organ failures, after giving conservative treatment, pictal drainage, till patient is not improving, then we don't have other choice. So you have to go in. Either you have to do ward or you have to go transgastric approach.
I think this thing, going by this, nowadays we are following step-ups.
Yes.
So first 3 to 4 weeks, the role of IR is more than us or medical guys.
Yes.
Many a times the patient is very sick, so we do. So as far as possible, we do it late, but it's not hard and fast rule. We have to see the patient and decide when to intervene. My medical colleagues, do you agree with this, or when do you do endoscopic drainage? Do you purposefully wait for 4 weeks for well capsulation and all?
Sir, the issue here is that the wall should be formed.
Okay.
We do not have a limitation for the size of the wall.
Yes.
It can be 1 millimeter or 2 millimeter as well.
Okay.
But it should be a completely walled off collection. So
Okay.
till the time the wall is formed, we can do a necrosectomy if the patient demands it to, because
Okay.
if he is septic and other conditions.
Okay.
But otherwise, we wait till the wall is formed.
Okay. Thank you. So these slides are provided by Dr. Sagar. Would you explain them?
So this was a young guy presented post-COVID. He had necrotizing pancreatitis. He presented with a cholangitis, jaundice. So that time he had underwent ERCP stenting for cholangitis. Later he presented with next CT, sir. So you can see there is a necrosis with air foci inside. So he presented with the infected pancreatic necrosis. So that time I went directly because young guy presented with fever, high WBC count, procal was raised. So I went upfront for surgical necrosectomy in this. So I had done an open necrosectomy in this. So you can see, can we play the video? So that was, can we pause the audio? So I had gone in a lesser sac, I had not gone in a transgastric approach. So after opening the lesser sac, there was a bulge and it was all woody collection kind of thing. So I opened the pancreatic capsule. So it was all necrose thing. You can see I am pulling it with a Babcock. I had given a wash also. The whole pancreas was necrosed in this. So it was densely stuck necrosum. So I had done a necrosectomy. All pus was also drained. And after necrosectomy, the bile duct was also necrosed, so the bile started coming in the cavity. So what I did was posterior wall of stomach, I anastomosed to this cavity so that bile will drain, and also the whole pancreas was removed in this.
I'll pause the video a bit here. I have a question. Dr. Bhoi, would you like to answer? As surgeons, we can approach a lesser sac collection either through stomach or in between stomach and colon in the lesser sac through the omentum, or we can go retrocolic or infracolically through the mesocolon. So when you decide how to go, what is the determinant, or is there any preference for transgastric or anything?
If that wall of necrosis is restricted to the central part of the pancreas, then it is okay to go through the transgastric majority of times. When you are seeing patient is on the acute side, is close to the 4 weeks, then it is very difficult to go through the lesser sac approach, because acute condition there is lot of adhesions, omental adhesions, small bowel adhesions, you cannot get a space properly. So and that time your safe part is through the stomach. Anterior wall of the stomach is good enough to identify and go through the posterior wall and do a necrosectomy. But through the lesser sac, it is very difficult because you cannot differentiate colon, small bowel, stomach wall. Everything is stuck because of pancreatic juice. Everything is liquefied. So getting space is very difficult, sir.
So all these walled off necrosis and large collections especially are mollycoddling with the blood supply of transverse colon. So how commonly do you do an ileostomy?
So if during a exploration, if we found there is a pregangrenous changes are there, or a dusky ileum, or if there is air foci like this, and if I am suspecting there is a colonic fistulization, that time definitely I do ileostomy.
Okay. This was the entire cast of pancreas, I think you removed in that case.
I would like to add two things.
Yes.
The previous slide, first CT which we had given. See, now here, if you see the WPN, the next one. WPN, you see a crippled wall and air within that. So many of the times, if you expect that it's a infected collection, it should have been increasing in size rather than it has decreased in size and the approximation to the stomach has reduced. So I would suspect that there is a fistula somewhere within the duodenum or within the antrum.
Okay.
And that is why possibly when Sagar was doing the necrosectomy, he found bile there.
Yes.
So there should be a fistula which is bile was coming through the fistula into the cavity.
Okay.
So of course in his necrosectomy, he has done the complete necrosectomy and total pancreas was removed.
Okay.
But in other cases where there is a disconnected pancreatic duct,
okay.
so there are chances that after this he will develop a pancreatic fistula. So in such cases, if you do an upper GI endoscopy and identify the fistula and put in a stent there,
okay.
so you have an internal drainage there for the patient, so that the chances of pancreatic fistula reduce.
So beforehand an upper GI evaluation would have been better in this case.
You should do that.
Usually I get an upper GI endoscopy in patient if the patient is stable enough to do that. So let's discuss another case. A 40-year-old male patient, 5th week of acute pancreatitis, had also some calcifications in the uncinate. Sorry for the spelling mistake. It's ethanol-related pancreatitis. His LFTs were normal. CBC's TLC was around 16,000. CRP was raised and persistent for fever for 5 days. Patient had a large retrogastric collection, but he refused endoscopy, he refused surgery. So we requested our radiology colleagues to put a pigtail. They put it. Patient was fine for next 7 days, but again patient started spiking. The patient not eating well. So we placed an NJ for nutrition. So we did a CT at this juncture. So this is the CT. You can appreciate that there are some calcifications in the uncinate. And if you can appreciate, I had given rectal contrast also to this patient. So I'll stop it around here. Up. Yeah, here. If you can appreciate, this is the pigtail coming in. And if you can see, there is collection residual. Still, despite pigtail, this collection is not getting drained. There are air foci, if you can appreciate. That's why I had given a rectal contrast to this patient. So, next thing, patient again was refusing surgery. So I requested our radiology colleague to upsize this pigtail. But this pigtail was fairly big, 14 French in size. They refused. So how big a pigtail you can put, Dr. Patil?
Sir, like we can upsize it up to 18 French. Okay. And I would prefer placing a Malacot catheter rather than a pigtail catheter. A Malacot catheter with multiple side holes created before putting it.
So would you add on another pigtail here in this particular case?
Yes, sir. Because if you scroll the image, sir, you can see that the pigtail and the collection, like the pigtail has drained one collection.
This collection is
posterior to that
pigtail.
collection, sir.
Okay.
So I think adding another pigtail and like rather than pigtail, I would prefer a Malacot with multiple side holes, sir. So usually what happens is the pigtail holes are very small, and because of the necrotic nature of the collection, they get blocked very easily.
Okay.
So that is why.
So here worry was getting to this collection because getting a window was difficult, already a pigtail in C2. So what we did, we took the patient to OT, called our radiologist guy, we marked the collection, and under sono guidance, we marked it, and layer by layer, parallel to the pigtail, I went in, landed up in the collection, put a 10 mm port there, drained the entire collection, and put another big drain there, and came out. Patient is better. Unfortunately, I could not record the video at that time. I think Sagar has one similar experience with another case.
But in that actually there was no liquid component. It was mainly a solid component, which is difficult to drain with pigtails.
Okay.
The other option would be that through the pigtail, you can put a guide wire, dilate that particular track and put a esophageal stent there.
Okay.
So if you put a esophageal stent there, you can pass an endoscope through it and do a direct necrosectomy.
Okay. Is it SEMS, esophageal SEMS that we use for
for dilatation?
Okay. And regarding Sagar's case, another case of Sagar, can you tell?
So this patient, young chap, presented with acute necrotizing pancreatitis. So on day 30th, I opened this patient from left flank approach. So the next image, the collection was entirely going on the left paracolic. There was a collection as well on the right paracolic region also. So what I did was a left flank incision was taken, all the liquid component was drained, and after that solid component was drained, I usually use a wound protector, put a gloves to that, and through that I can insert 4 or 5 laparoscopic instruments, and through that I can do necrosectomy as well as I can put a scope and see entire cavity, is there any bleeding or anything like that. So only thing is when we are doing necrosectomy, we have to be very gentle pulling the tissues, not to pull very harshly or rapidly, not to break the tissues, and gentle necrosectomy is important, and very important thing, not to break any strings. These strings might be blood vessels which we feel with the fingers. And at the end, I irrigate the cavity and see through the laparoscope, and you can see the necrosis there after draining the pus. And I put 2 drains so that one I can give irrigation and we can put a drains also. We can get the drainage. So through the retroperitoneum approach, small incision, I am doing necrosectomy. So that was, so as we see, the necrosis was up to the pancreatic neck. Through the flank also we can reach up to the neck. On right side it is difficult because there is a duodenum, but from left side definitely we can go anterior to the kidney and drain all the collection, take out the necrosis. You can see the necrosis was taken out completely. There was about 3 to 4 liters of pus.
So, as we are coming to management, so each of you...
Just a minute. How difficult it is to go in the retroperitoneum? Because with all these adhesions, colon...
No, there will be sonography, we do it. We can put a pigtail or we can aspirate, and along that catheter, we take a small incision, about 4 or 5 centimeter, and layer by layer we keep on going it.
That pigtail is guide to...
Yeah, pigtail. Along the pigtail we should open it. So it is very less likely that we will injure the colon or anything.
So I think we have discussed this already. Everyone is abiding for the step-up approach, and only in selected cases, as Dr. Boy had well explained before, that there are certain indications for going upfront surgeries, but most of the cases we are going to abide by step-up approach. So this is the trial. This is for summary of the trial that changed everything actually. Panther trial. This was to compare minimally invasive step-up approach versus primary open necrosectomy. Main conclusion was that major complications rate was less, 12% versus 40% in open. And this trial changed the way we managed pancreatic necrosis. So as we are discussing regarding the collections, is there, as we see 2 examples, one by Sagar, the other one was central, distant from stomach versus opposed to stomach. I'm going to ask this mainly to medical colleagues of mine. How does it make a difference?
Definitely makes a difference, because having apposition to the stomach helps the endoscopist to perform the US-guided necrosectomy, placing a stent. The distance from the stomach, as it increases, more the case goes to the either radiological intervention like putting PCD or surgical.
Yes.
So having a good apposition with the stomach, it definitely helps for the endoscopic drainage.
So, as a surgeon, what I feel is that most of the collections opposed to stomach duodenum are treated primarily by medical colleagues of us. They do it transgastric most of the times, if I'm not wrong. And those who are in periphery, they are primarily tackled with radiologist colleagues of us, and then we go in. So, surgery is nowadays getting restricted for this thing. So, coming back, my original question, is surgery extinct for primary collection? Yes, in a way, but still there are indications wherein you can go primarily, but most of the times it is other medical gastro colleagues or radio colleagues of us who are managing it first, and we come second time in the picture. And also regarding this transgastric drainage, since we have discussed cologram and all, have you done any time endoscopically through colon or something?
Yes.
May not be primarily, because going through
Yes.
colon is not a very great idea to reach this thing.
Not a primary drainage.
Yes.
It is not recommended.
Okay.
Transgastric is a better approach all the time.
Okay.
But we have a case series which we had presented in DDW this time.
Okay.
Of about 20 patients.
Okay.
So they had air within the WPN.
Okay.
And they had either fistula in the most thin-walled segments of the bowel, that is either duodenum or in the transverse colon or in the descending colon.
Okay.
So when we did the scopy, we were seeing a necrotic debris which is impacted at that fistula site in the colon. And then we kept on removing those necrosis from that particular fistula. And then we were able to even pass an endoscope through the fistulous opening into the WPN cavity.
Okay.
And see that everything is cleared.
Okay.
So that one possibility is there. You should not intentionally do a colonic drainage, but if there is air within the WPN and you are suspecting a fistula, things will be much easier than a surgical drainage.
Okay.
Yeah, I agree with Aditya that if there is a colonic fistulization, intentionally it should not be done, because these are the patients who are very sick because of fecal transmigration and fecal contamination. So these patients will be in very much sepsis. So usually we try to go surgical approach and do prophylactic ileostomy also in these situations, so that contamination will be prevented. So
Okay.
patient should not be going in repeated sepsis, gram-negative sepsis.
Pictures.
Just for knowledge, Aditya, is it possible to do stenting in these patients?
Where?
Colonic fistulas. Can you put stent for healing of the fistula?
We can use plastic stents, no metal stents.
You are talking of colonic stent.
Yeah. See,
colonic stenting?
Yes. They not colonic stenting. Through the fistula into the WPN we can put. Now in this image we can see that first there was a WPN collection. Then it was ruptured with, there are some air pockets seen within. So when we did colonoscopy, there was this impacted, in the first picture, impacted here, impacted necrotic material in the fistulous opening. When we kept on removing that, then we saw this fistulous opening. And when we went inside, this is the WPN cavity which we transgastrically also we can see. And we had put in a plastic stent. So there was a, if you can see this first, after the colonic stent, there was complete resolution of that particular WPN cavity. So we have around 20 cases of such this thing. So that is one easier way to do it rather than subjecting a patient to surgery in case there is a spontaneous fistulization.
So what we discussed now, classifying these collections as central, peripheral really helps in management of this, as also seen in this article. So there are various approaches of appearing a wall of necrosis to sum up the management. So we have to tailor it to individual patient. So this slide was shared with me by Dr. Sujay, wherein he had done EUS guided necrosectomy for this one. So this is what how done endoscopically. So we have seen surgical management, we have seen endoscopic management. So I would like to tell Dr. Patil to tell a little bit about radiological management of this. So he's going to discuss one case.
I am going to discuss about a percutaneous necrosectomy done. So she was a 29-year-old female patient. She had complaints of pain, vomiting, decreased urine output, and was evaluated to have severe acute necrotizing pancreatitis. She was very bad. So she was fluid resuscitated for persistently low BP, decreased urine output, and was shifted to MICU. In view of respiratory distress, she was initiated on NIV followed by mechanical ventilation, and a CT abdomen was done which revealed multiple acute necrotic collections. So there were multiple collections in various parts of the abdomen. So they were in the right and left paracolic gutters and in the peripancreatic region. So multiple PCDs were placed. As we can see, there are some 4 PCDs placed. Most of them are Malacot, and if you can appreciate, there are side holes made. These are the side holes which you can see over here. So these are the side holes. So the side holes are made, and in this video you can see this is a percutaneous necrosectomy is done, in which we place a guide wire through the PCD, and the Malacot catheter is inserted into the wand, and then it is rotated such that the flower of the Malacot will catch hold of the necrotic material. So we can see that the necrotic material which was taken out. So the guide wire is in place. So when we take out the PCD, we take out the necrosome out, and then again reinsert the PCD and do it. So this was the necrosome material which was taken out, and this was the pus which was aspirated. So in very bad patients, this can be done. And in the next slide, we can see that there is almost near complete resolution of all the collections, and she didn't need anything else.
So comparing now, we have got 3 modalities to tackle with WON. So which do you think is safe? Each of you can answer.
I feel every case is different. So we have to discuss it with a gastroenterologist, interventional radiologist, and depending on the condition of the patient, whether there is organ failure, sepsis, depending on those, which is safer, by step-up approach, we should use that approach.
Abhishek?
Safe is to treat patient in such that the patient should not land in such kind of misery.
Okay.
And that can be done by the judicious fluid replacement in the first 40 to 72 hours and early enteral feeding. Because that has, in all studies, shown that that prevents everything. Even though we have seen patients where 8 by 10, 10 by 10 patients are there. They are bound to have, or in future development of the WON or everything.
So,
but by initial management in the form of proper judicial fluid replacement, enteral nutrition, the complications where such kind of things are going to be required, like AR or infected WS, that can be prevented. So the alteration of the prognosis can be done only with the 2 simple things, fluid replacement and enteral nutrition.
Is there any role for gut decontamination to prevent infection, like rifaximin? No role.
Enteral feeding itself is best treatment approach for it.
How much to give fluid in first 48 hours? How to decide? What are your criteria?
1 ml per kg per hour. Initially, there was an aggressive fluid replacement protocol where they used to give a 2 ml per kg per hour, but that has been shown to increase the more inflammatory response. So now there is a judicious or the control where 1.5 to 1 ml per kg per hour.
I think post-waterfall trial.
Yes.
Waterfall trial is recently published in NEGM.
1.5 ml.
1.5, not 1 ml.
So these are.
Depends on the creatinine status also.
Yeah. These are eminent trials comparing randomized control trials, endoscopic versus minimal invasive approach, penguin, tension, and Miser. Just in listening in, not going too much in detail of this. So it is, all methods are fairly safe, only that you have to choose patients accordingly. There is a meta-analysis of 1980 patients. So risk of death is very high. At that time, minimally invasive surgical necrosectomy is better than open surgical necrosectomy, or endoscopic is better than open necrosectomy. Usually morbidity is lower with minimal invasive and endoscopic compared to open necrosectomy. So my question now to my medical gastro colleagues, EUS when? All cases or selectively? Or
if it is a perigastric collection and you have to drain it,
yes,
definitely you need to do EUS.
Okay.
To see the feasibility of doing it. And EUS gives you a better idea about how much amount of necrotic material is there, because you are quite opposing to the wall of that particular thing. So depending on that, we usually, before the drainage, we try to do an EUS.
My follow-up question regarding choice of stent.
If it's pseudocyst, plastic is better, but if there is more than 30% necrosis, obviously then we have lamps or Nagi stent, metal stents, because you can dilate them with the balloon and you can enter with the normal endoscope and you can do stepwise necrosectomy.
Okay.
It also depends on the size of the pseudocyst. If they are more than 10 centimeters, sometimes even if it is clear, we can put a metal stent, because sometimes incomplete drainage will cause more infected collection in there.
So Do you routinely go for multiple passes in such cases? 2 punctures or 3 punctures?
No, not routinely.
Not routinely.
Usually one, but if it is multiloculated collection and if the other part is not draining with the primary drainage, then you can go ahead with a multi-gated approach.
Madam, should we stay with the time or wrap it up fast?
Yeah, what the floor says. They are hungry?
Continue.
Okay, continue.
Plastic stent versus metal stent. This is the efficacy of plastic stent with plastic stents for treatment of walled-up pancreatic necrosis by Zafar and colleagues. So slightly favoring metal stents in especially walled-up. So what we discussed. In pseudosis it's okay, but in walled-up necrosis prefer lamps. Again, what are your criteria when you decide to refer to a surgeon?
Usually now, recently now the classification of WPN is a QNI classification.
Okay.
So that is quadrant, amount of necrosis and infection.
Yes.
So if it is a quadrant which is involving more than 2 quadrants, then of course it's a multidisciplinary approach.
Okay.
So either with a surgeon or with an interventional radiologist. If it is perigastric, then of course it is and step-up approach. Endoscopy should be the first option.
Okay. So coming to surgeons, so what's your choice between these two? Laparoscopic versus open?
Transgastric, if we are planning, if it is a well collected and loculated collection, anyways laparoscopic is the best.
Okay. So
but not in an acute phase, and
yeah.
patient should be stable, not in sepsis.
In well-loculated and very well-intended collections, actually this patient, I and Dr. Killara ma'am did in Bharti. We went transgastric and we could do a very good necrosectomy and close primarily the anterior gastrotomy also. And patient did well. Patient was a well candidate for LAMS placement endoscopically also. Could have been managed endoscopically, but the patient was non-affording, so we had to go in. Regarding open approach, if you can observe, I have put one Foley's catheter here. That is for irrigation. So, Dr. Bhoi, do you use it irrigation regularly or only in selective cases?
Yeah, it depends upon the what I am going to do approach. If it's a transgastric, I am putting naso.
No, not for transgastric. For
open,
open
yes, I am
necrosectomy.
putting. Yes, I am putting one.
And
but we are putting not. We are putting Foley's.
Okay. So, what's your tube of choice for irrigation then?
We are putting soft drain, sir.
Soft
Majority
drains.
of soft drains.
Even for irrigation?
Yes, sir.
And what are your endpoints for irrigation? How long you proceed with irrigation?
You are seeing the output of the drain.
Yes.
And if it is still it is coming thicker and still patient is having symptomatic is not relieved, we are continuing draining.
Okay.
So whenever patient is settled down symptomatically and the drain output is almost clear,
okay,
then we are decreasing eventually, sequentially.
So with that discretion you decide, not a fixed protocol for removal of drain?
No.
Long-term irrigation have you used for any particular case or something?
If it is a total abdominal infection is there, not for the 1 or 2 quadrant infection, so not needed long-term.
Okay.
But if it is all 4 quadrants is totally infected, then we have to give it with it.
And adding an FJ, how common do you do?
FJ?
Feeding jejunostomy.
If there is any duodenal pathology, then only we are going in.
Okay.
Or else we are not going in.
Okay.
And in that part of situation, it is very difficult.
Yes.
It is very difficult because whenever you will find the duodenal is perforated, if duodenal injury is there,
okay,
you are going inside and seeing all these things is very difficult, even though you are doing open.
Okay.
You cannot differentiate the bowels.
Okay. So between NJ and FJ, what would you prefer if given a choice?
Usually in esophageal tube, I will not prefer feeding jejunostomy because these are sick patients, nutritionally bad, and opening, making one more hole in the bowel, that can cause problems itself. So usually I don't. But when there is a good loculated cavity, I don't do irrigation, but irrigation preferably when there is a not well loculated cavity.
Okay.
And usually I prefer Jackson-Pratt drain. That is a soft drain with multiple holes.
Okay.
So that drains very well and it doesn't block also.
Is it freely available or locally here in Kolhapur?
Yeah, it is available.
Okay.
Yeah.
Regarding this thing, ward and lab, I think we have already discussed. Dr. Boye had told indications for lab. Ward is basically for retroperitoneal or peripheral placed collections, wherein rather than going transperitoneal, going retroperitoneal is a better approach. FJ and stoma. Stoma, I think we had already discussed, and FJ also we discussed now. This is also we have discussed. Always the first line or not. So I'm skipping this question. So coming to all panelists, what you see as the biggest controversy in world of necrosis today?
Who will be first?
Anybody?
Either gastroenterologist or interventional radiologist or surgeon, who will be the first to treat this case?
Who first is the biggest controversy now?
Or to whom?
Whosoever the patient comes first, usually.
Yes. So that is the thing.
And
yes. I would like to add one point. If you see the Miser trial, or tension trial,
okay,
and they both Miser trial is getting very low, around 22 cases, but in tension trial still it is going on. It is a 7 years of follow-up period.
Okay.
They have tell in that conclusion is that if you are managing patient with the endoscopically, that early patient recovery is very good.
Okay.
If you are seeing to 6 months. But for the long term, in the tension trial, they have mentioned that if after 7 years of follow-up, those who are treated with surgically, their outcome is much more better than the endoscopically treated cases.
Okay.
So upon that, if you are seeing for the short-term period, endoscopic approach, no-touch approach patient to treat the patient is very good. But there is chances of recurrence again.
Okay. So, what one change do you predict by 2030, when next guidelines come up for one? Or will it be the same, not whatever we are doing now?
2030, AI will decide.
So, long term, I am concluding with this case. This was 21-year-old boy, idiopathic pancreatitis, acute pancreatitis. In January, he had got external drainage of wand done. He improved. But the problem that he developed persistent fistula around 100 ml of clear fluid daily. And whenever the drain was clamped, he used to have fever. So there was no scope for removing and clamping the drain. ERCP was tried. There was a tight stricture in the neck and could not go beyond, and stenting was not feasible. So this is one of the banes of doing percutaneous drainage, and what to do. Tube left like that. This was disconnected duct. I think Dr. Vaibhav Patil had discussed previously. So in this particular case, I went in, did a distal pancreatic splenectomy. My problem, and I would like to discuss with my surgeon colleagues, do you do, in such a case, if you're doing distal pancreatic splenectomy, do you add a PJ to the remnant or primarily close the stump?
No, sir. Usually I will not. Because again, if PJ leaks,
yes,
that will be hell for the patient. That's why. It's better to transect and leave it.
I have done around 4 such cases for this disconnected duct and DPS. All of them have developed diabetes within 6 months. That is a problem.
That is depend upon the how much remnant parenchyma is functioning.
Yeah.
If ductal disruption along with the head necrosis is there,
yeah,
even though you are doing distal pancreatomy, if head and ancillary process is not functioning,
okay,
then you will end up in the future diabetic patient.
So, Sudhanshu, can't we try stenting, PD stenting?
It was tried, sir. It was not feasible. ERCP and PD stenting was tried. Multiple attempts were made. Could not be. Tight stricture in the neck.
Other thing, sir, what we can do is if the pigtail is in place, pigtail is in place, we can instill water through the pigtail.
Yeah.
And insufflate that particular WPN cavity.
and then do a gastrocystostomy as we do with plastic stents, so that you divert the pancreatic fluid towards the stomach internally.
Okay.
So you can instill water and do a EOS gastrocystomy.
Yeah.
Yeah.
Yeah. So take-homes that I have enlisted are?
Sudhanma sir.
Yes.
Harshal just said in tension trial, either surgical has given long-term good result or no-touch policy. And majority of us will have, many patients, we are no-touch policy only, because they will be carrying their wand like that, because they don't fulfill the criteria of any kind of intervention, be it endoscopic, be it a surgical, or be it a pigtail. So in no-touch, the only thing that helps is adequate nutrition. Because I myself have 2 to 3 patients who had wand for almost a year, and with a good nutrition, they have resolution of wand almost after a year later. So the enteral nutrition is the best thing that can happen to any patient in pancreatic necrosis.
So in asymptomatic pseudocyst
Hmm.
and asymptomatic
Wand.
how long to wait?
Wait till 6 months, 1 year. You can
completely
yes,
wait.
yes. Wand can be treated in the absence of any complication like no-touch policy.
And there are few situations, with your permission,
Yes.
when there is huge chelation in acute cases, and patients all the time they are saying, sir, there is a lot of distension of them, they are not comfortable. So do you consider percutaneous drainage in such?
Indications are pain. That is the first more indication. Second, intractable vomiting, and third is a fever.
Mic, please.
So 3 indications are pain, intractable vomiting, and infection fever. So 3 of them are coming, or any one of them you can intervene. But there are many patients, like they must be having 150 cc collection in the tummy, 10 centimeter large collection, but they are comfortable. They are going like their normal routine life, they are roaming around, they are eating everything, there is no vomiting, no pain, then you can have no-touch policy.
No, my question was in acute pancreatitis, when they come with huge pancreatic collection or in flank collection, the abdomen is distended and patients are very, they are not comfortable. And every time they are saying,
drain that.
Sir, relieve this.
You should drain.
You should put pigtail and drain it.
No, you should first see whether it is a pancreatic fluid or not, first. After that, that management will be changed like that. Either it is that fluid amylase will be less or more. All the management is depend on that.
No, diagnose acute pancreatitis, diagnose, and there is huge collections. Can we put pigtail and
Definitely.
symptomatic relief for patient?
Definitely.
Okay. So these are the take-homes of this discussion. Anybody would like to add anything to this, or it's okay?
Sir, nobody said one more controversy is there, very big controversy, whether to do ERCP post drainage of the wand.
Okay.
That is a big controversial topic. Even in gastroenterology, it's a controversial thing. I don't know, Aditya, what does he feel?
I think if it is a disconnected pancreatic duct, what he said was there is recurrence. So in recurrence, one thing is that if there is a disconnected duct, there should be a stent for internal drainage of the residual pancreas. So either you can do a ERCP and do a PD stenting, or if you have already put in a plastic stent, that should be kept alone there. Or if you have put a metal stent, you remove it and put in a plastic stent there, which is going to be there lifelong possibly.
Just I'm talking of plain simple wand, if there is a drainage done. See, the understanding is all wands are communicating with the pancreatic duct, some branch somewhere, because that's how wands develop. So there are people who do ERCP after every drainage of wand, because they say there's a theory that if you do a syncrotomy of the pancreatic duct, most of the drainage will happen naturally instead of going via the other way.
What we do, our protocol is we drain the pancreatic fluid initially. After the drainage, we get a good MRCP done to see and study what the pancreatic duct anatomy is. And depending on that, we decide which kind of internal drainage you need, whether it's a ERCP guided or whether if you have already done an endoscopic therapy, then keep that particular stent for as long as it can remain.
I think
of the cases during follow-up scan, the pancreatic parenchyma, if the proper initial treatment is good, it has resolved. It is mainly peripancreatic fat that gets melted and that forms wand. So in that case, MRCP helps us whether that communication is there or not. In that case, you can have a trial of putting a PD stent. But if it is purely peripancreatic fat melting and pancreatic duct is on MR, so that's where MRCP helps. Whether you are getting communication after 4 weeks with that collection.
Thank you. We have already run out of time. I want to thank organizers of Dsgecon for giving us an opportunity. And I would like to thank all our panelists as well as all esteemed delegates who have put in their valuable inputs for this. Thank you very much.
Thank you, Dr. Sudanva. I request all the moderators to felicitate Dr. Sudanva for conducting this session. Thank you. I request Dr. Smita Dharamsi and Dr. Malgave Madam, the scene behind the whole of the success of the conference. They are sitting here to felicitate our moderators. Malgave Madam and Dharamsi Madam will felicitate our moderators. They are sitting here. For arranging the conference, sir may not be in the home, but everything is handled successfully. Thank you, Dr. Malgave, Dr. Dharamsi Madam. Now I request Dr. Dharamsi sir for inspiring speech. It's not there. Okay. Okay.
Friends, I don't think there's any need for inspiring speeches. We are already all so inspired. If we keep on going on like this, we'll probably expire also. So, forget about inspiring speeches. The thing I would like to tell is that DSG has done very well. It's about 21 years and a half that we have formed DSG. It was on the 8th of January 2004 that 35 of us met and decided that we want to form the DSG. We didn't know what we were going to do ahead, but yes, we wanted to form a DSG. We wanted an association where we could get together and discuss and motivate. So following that, in September 2004, we had the first meeting in Mahabaleshwar, which Nagi referred to when he was talking yesterday. That was the first meeting, and DSG was inaugurated by Nagi, G.V. Rao, Prabha Sawant, Amit Maideo. So they helped us set the ball rolling. And over the last 21 years, except for that short period during which we had COVID, we've been having 2 meetings a year, and all of the meetings have been good. We have had fairly good discussions. We've had a couple of live workshops, all of which were very good. We had this lovely transmission of live workshop from Bombay and Hyderabad, and I think we had a very good session yesterday. So over 21 years, I think we have done very well as a unit, as a body, as a association of persons who are interested in one part of the body. And besides that, we've also grown as a family. Actually, DSG is not an organization of individuals, it's a family organization. We, each of us, like to entertain everybody in the society. So it's also kids and the wives or the spouses, and that has been the major force of the DSG. We go once a year on trips in India or abroad, and we have done lovely, last 10 years we've done lovely trips, including at least 3 trips abroad, Bhutan, Kenya, and Azerbaijan. So this has been growing very lovely. What I would say is think bold, be bold. Let us all become still more stronger. Let us see that we continue the good work of DSG. We've lost some of that because we are not doing charity work. We tried a few years back, but we went to all the jails in Sangli, Kolhapur, Satara, Sholapur, and we checked the inmates for hepatitis B and then gave them 3 shots of hepatitis B vaccine. And I think that was a wonderful social work that we did about 6-7 years back. But after that, we have run short of ideas. I think that's one aspect we need to concentrate on. We need to become social people. We need to do some charity work for people. It is not just showbazi. We have to do it genuinely. Besides that, personally, I've been very happy with DSG. I have some of the best friends in my life are from DSG, and we all get along very well. I think that was also one reason for having the DSG. We wanted everybody to gel with each other. We are all doing the same practice, but I think we have set a trend that we gel with each other, we help each other, and there's no jousting, there's no backbiting from our members or another member of the DSG. So I think that's a very good thing that has come up. We should continue that camaraderie that we have and also do a little bit of charity. I think those are not many very interesting or very inspiring words, but I love DSG and I think you too. So let's keep it up. Thank you.
Thank you, Dr. Dharamsi sir. Now I request Dr. Abhiman Pawar for a vote of thanks.
Very good afternoon. So this concludes our Dsgecon, Monsoon Dsgecon 2025. First of all, I would like to thank all of the DSG members who have attended this 2 days conference. People, they have come from a long distance, right from Goa and Hubli and Dharwad, etc. So I would like to thank everyone. I would like to thank all the sponsors for giving us a warm sponsorship for the this conference. Also, I would like to thank Mr. Sharp Vision team, Praveen Ghadge sir and their team for arranging a fantastic workshop. And I think it was a glitch-free transmission yesterday from both the centers, Hyderabad and Mumbai. And all of us, we saw how the clarity was very good. And again, I would like to thank Cocoon Hotel for arranging for the good hospitality and the nice food and every arrangement. And once again, all the patrons, especially Dr. Dharamsi sir, Uday Singh Patil sir, Lokur sir, and these are the founder members and who have given wholehearted their support to conduct this conference. And with this, I won't stay in between your lunch and everybody must be waiting. So thank you everyone, and I hope we'll see some such more conferences in the future. Thank you.
I request Dr. Abhiman Pawar to felicitate Sharp Vision for excellent audio visuals throughout the program.
That's what. Sangli. I request representatives from each pharma company to come forward.
Please come to the dais. One from each company. We have, I think, 16 companies.
request Dharamsi sir to felicitate our MOCs, Dr. Boma sir, Dr. Kilidhar ma'am, Dr. Divekar sir. I now request Dr. Dharamsi sir to felicitate our MOCs, Dr. Kilidhar ma'am. Dr. Bhumat sir. Dr. Abhay Divekar sir. Request Dr. Gujar sir, Dr. Sujay Kulkarni sir, Dr. Siddharth.
All good things have to come to an end. I request all of you to enjoy your lunch. Thank you very much.